Good afternoon. Welcome. This is the County Council's Health Scrutiny Committee, a new committee at the start of a new municipal year, and I warmly welcome everyone to it. Feel free to take pictures and use social media during the meeting, but please turn off your phones to silent or vibrate. And a reminder, the meeting is being live streamed and the recording will be made available later on the council's website. There is no fire alarm test scheduled for today, so if the alarm sounds, panic, or even better, I will adjourn the meeting and we will leave via the side doors. I'm pointing now to my left and use the fire escapes next to the kitchen. The assembly point is at the far end of the car park. I would like to welcome Jess Slater, who's on my right here, who's the Chief Executive of Health Watch Cambridge and Peterborough. They are not being scrutinised, but their representatives have an open invitation to submit evidence or take part in any of the health scrutiny sections alongside committee members and to ask questions. So thank you to Jess for joining us. The first thing I have to do is to move to the notification of the Chair and Vice Chair. Rashenda, if you could kindly do that, please.
Thank you. The committee's asked to note the appointment of Councillor Richard Howitt as the Chair of the Health Scrutiny Committee for 2025-26 and Councillor Anna Bradnam as the Vice Chair.
So thank you for those appointments that were made at the full council, and I think both of us have hit the ground running. We've had a lot of meetings so far, but it's great to get to the first formal public meeting of the Health Scrutiny Committee, and we're really looking forward to the task. As always in this function, it's a joint function between the County Council and city and district colleagues from throughout the county. We are co-opting them, but otherwise they play a full and equal role with every other member of the committee. And I really do apologise to people, some of whom I know very well, but I have to ask you for a very few seconds to leave the room whilst we formally go through the co-option process. Sorry. I'm not nervous still. No. Item 2 is the appointment of co-opted members. The committee is asked to appoint the following representatives of the council's district council partners as non-voting co-opted members of this committee for 25-26. Councillor Corinne Garvey from South Cambridgeshire District Council, Councillor Keith Horgan from East Cambridgeshire District Council with a substitute of Councillor Julia Huffer, Councillor Dr. Haq Nawaz from Fenland District Council, Councillor Ben Pitt from Huntingdonshire District Council, and Councillor Mike Todd-Jones from Cambridge City Council. Any alternative suggestions? Anybody want to make any objections to any of those names? I'm seeing nods around the table, so that those are all approved unanimously. Sophie, if you could ask them to rejoin. So I'm sorry to make you move around a bit like that, but it's be the last time in 3 or 4 years that we'll be separate. We'll be working collaboratively and collectively throughout the process. I'd particularly like to welcome Councillor Pitt and Councillor Todd-Jones, who are new to this health scrutiny function in this mandate, as well as Councillors Kane, Malinowski and Martin, who again are joining this function for the first time. So you're all extremely welcome. It's extremely interesting and I hope you'll enjoy it as well as us do some good work all together. I think because we're new and people are getting to know each other, I am going to go around the table. And I'm Richard Howitt. I'm County Councillor, Chair of the committee, and I represent a ward in Cambridge City Petersfield ward on my right.
Thank you and welcome everyone. I'm Councillor Anna Bradnam from the County Council and I represent Waterbeach Division.
Gender, please.
I'm Rishenda Greenhill. I'm a Democratic Services Officer here at the County Council and I support the Health Scrutiny Committee.
Councillor Martin.
Councillor Ross Martin, County Councillor for the Warboys and Stukely Division.
Councillor Dr. Hack-Nawaz.
Hello, my name is Dr. Hack-Nawaz. I'm a councillor for Fenland and I come from Whittlesea. Thank you.
Thank you. Councillor Pitt.
Hello everyone, so my name is Councillor Ben Pitt. I'm from St Neots, my ward is St Neots East and I'm a District Councillor for Huntingdonshire.
Thank you. Councillor Todd Jones.
Hello everyone, I'm Councillor Mike Todd Jones. I'm a City Councillor in Cambridge representing Arbury Ward.
Thank you. Jess Slater.
Good afternoon, I'm Jess Slater. I'm the Chief Executive for Health Watch Cambridgeshire and Peterborough.
With apologies, I'll pass over our next speaker, who I will be introducing in a very few seconds, and I move to Councillor Malinowski.
Councillor Jennifer Malinowski from Burwell.
Thank you very much. You're very welcome. Councillor Horgan.
Yes, thank you. Councillor Keith Horgan, East Cambridgeshire District Council, representing Soham.
Thank you. Councillor Garvey.
I'm Corinne Garvey, District Councillor for Girton, Drogheda and Madingley.
Thank you. Councillor Dupre.
Councillor Lorna Dupre, County Councillor representing the Sutton Division of East Cambridgeshire.
Thank you. Councillor Kane.
Councillor Sarah Kane, County Councillor representing Sydney, it's East and Granston.
Thank you. Sally.
Sally Cartwright, Director of Public Health for Cambridgeshire.
And Patrick.
Afternoon, everybody. Patrick Warren-Higgs. I'm the Executive Director for Adults Health and Commissioning at Cambridgeshire County Council, Officer supporting the committee.
And I'm being reminded, everyone's have your microphone quite close to your mouth because it's needed so that people can hear you properly. Okay, so that's everyone. Thank you. You're very welcome. We now move to apologies for absence and we ask Rishenda to comment on that, please.
Apologies received from Councillor Osborne.
And thank you, does any member wish to declare any disclosable pecuniary interest or non-statutory disclosable interest to the meeting before we start? And could I just announce several members are governors of health trusts. When representatives of those trusts appear, I don't regard it as a conflict of interest. So I'm saying that now to go in the minutes so that that doesn't become a constant discussion point over the course of all the years. I think where there are representatives of councils that are involved with health bodies, their contribution is welcome rather than unwelcome. So I'm just going to say that right now at the beginning. So we move on to our first substantive item, annual health checks for people with learning disabilities. That's on pages 5 to 52 of the agenda papers we've all received and which are published on the website. This follows on from a scrutiny session in December of 2023, looking at improving health outcomes for people with learning disabilities. This identified that annual health checks as a key part of this process, but one where there were some inconsistencies in its deliveries around the county and where service user feedback suggested improvements could be made. We're pleased to welcome Carleen Allen, Deputy Chief Nurse at the Integrated Care Board. Our thanks for joining us this afternoon and for the report that you provided ahead of today's session. I also want to place on record my thanks to members of Speak Out Cambridgeshire for sharing their annual health check survey 2024 with us, also in the papers. This captures the voice of local people with learning disabilities and is absolutely central to today's session. This survey reflects their preference for how they wanted to share their experience with us, and our thanks to Graham Lewis at Healthwatch for his role in facilitating this. I will begin by asking Carleen to briefly introduce her report And then I'll ask Jess Slater if she has anything she wants to add at this stage from Health Watch, and then we will move into committee questions. Colleen Allen.
Thank you, Councillor. As already alluded to, I'm responsible for the commissioning of children's services, learning disabilities and autism for Cambridge and Peterborough ICB. My report today is around an update on where we're at with learning disabilities annual health checks. I'm going to assume that the papers have been read and that I will just give you the key points from the papers and then open to any questions that would be very welcome. And just to say thank you very much for giving me this opportunity to share the progress that we've been making following the last report in 2023. Where we did see some significant challenges around access for people to get their learning disabilities annual health checks, and also just to understand what reasonable adjustments needed to be in place to enable them to be able to facilitate those health checks. We've done a lot of work with our leader programme, and we've taken our leader team, which is the learning from deaths and mortality reviews for people with learning disabilities. We brought the team in-house, and that's given us a lot of thematic reporting to identify why people with a learning disability are dying and why they're dying earlier. And we've taken some of that information and fed that into all of our training packages, and we've pulled together a report which will be available in November. It's an annual report that we update and will go online and be a public document, and it helps us to identify some of the themes and trends that are coming through. Early indicators for the leader report this year are suggestive of previous issues around early intervention and prevention, hence the reason why annual health checks are absolutely critical to people with a learning disability, and being able to access their annual health checks so that we can really identify early health issues and be able to monitor them and support people with a learning disability to either access mainstream health services or specialist learning disabilities services. So some of the themes that are coming through from our report that are in early indicators this year, once again, identify some themes around respiratory conditions, particularly community-acquired pneumonias and pneumonia once they're in hospital. And then the other area that we're concerned about, that we're doing quite a lot of deep dive work into, is cancer and the availability of access to screening and early screening for people with a learning disability, which once again should be picked up through that annual health check process, and is part of the annual health check proforma that should be carried out by all GP practices in order to gather the information from our people with a learning disability and autism. So we have identified that all of the practices in Cambridgeshire, there are a couple in Peterborough, but all of the ones in Cambridgeshire have signed up to the Direct Enhanced Service, which is commissioned through the ICB to ensure that practices are carrying out and accessing funding to be able to provide annual health checks for people with learning disabilities. We've done a lot of targeted work through a specific primary care team, contracting team, who are working with all of the practices to ensure that we are seeing an improved coding of people that have a learning disability. So we've seen a significant increase in the number of people that are actually aware that they're eligible for an annual health check and are able to access it. And then we are working with the practices to make sure that of those people that are now on the registers, they are getting their annual health checks every year. We have seen an increase in the uptake of those annual health checks, but there are 4 specific practices in Cambridge where we have seen quite low numbers of annual health checks being completed. So we are doing some very specific targeted work with those practices to ensure that we are making sure that the access for people with a learning disability is provided. Some of the issues that we've identified within those 4 practices are some issues with the way that coding and data is recording and making sure that they're being consistent in what they're putting into the computer data clinical systems so that we can cross-reference it. Some of them are moving from an annual review process to aligning it with people's date of birth, so that they will still get an annual check, but it will be on the date of their birth, as opposed to being backloaded all to the end of the year, which is what we were seeing previously, is that the numbers would be very low at the start of the year and then would increase significantly towards the end of the year. So by doing it aligned with birth, it means that it's more evenly spread out throughout the year, and we're able to keep on top of it much better and make sure that people are getting their annual reviews completed. And then a couple of the practices have done some further coding cleansing to make sure that they're on top of it. And then one of the practices has a huge amount of care homes and nursing homes that they have patients registered with, and people with learning disabilities in those homes. And they are doing targeted work in November and December. So we'll see an increase in the numbers happening in November and December for those people with an annual health check requirement. So those are the key things around the health checks that we've identified. We have seen already within Q1 of this year that there are 572 people eligible for an annual health check, which is significantly more than was identified last year. And we are on track with achieving the 75% target, which is what's set nationally for us to achieve, to make sure that a significant proportion of people are getting their annual health checks. One of the challenges that we do find with annual health checks, and it has been reported through the Voiceability survey with the Speak Out Council, is that actually people are much more aware now that they are eligible for annual health checks and how to access them. But part of the problem they are still finding is the reasonable adjustments that need to be put in place to help them. So making sure that there are slightly longer appointments, making sure that that the letters are made accessible for them to be able to understand and read and comprehend, and also to look at whether it always has to be a GP practice location or whether there's other alternative options that could be reviewed. So those are still some challenges that we are dealing with and working with the practices around to make sure that we are enabling and making it as easy as possible for people to access and get their learning health checks. And then once they've had their health checks, we're then working through how many people have had a health action plan off the back of it, which will help with that early intervention and prevention to enable people accessing health services where they require more intervention, i.e. around screening or with long-term conditions, support and management, things like diabetes, asthma, that sort of thing. In addition to this, we have also set up a learning disabilities improvement programme, which has been running now for just over 12 months, probably about 16 months now. And within that, we have a work stream around reasonable adjustments, where we have all of our community and our acute providers, as well as primary care representation there. And as part of that work stream, we are looking at how we can increase the uptake of hospital passports and making those accessible for people with a learning disability, so that they don't have to tell their story every single time, and that we are very conscious as they move through their journey from primary care, community and into acute trusts and out again, that they got that messaging following through with them, so people are aware that of what the reasonable adjustments are that need to be made to support them with getting their care needs met. And that's also a really good forum for shared learning about what works, what doesn't work, and how we can make sure that we're capturing the voice of people with a learning disability and also their parents and carers, to enable us to make sure that we're making those adjustments and changing our commissioning arrangements to ensure that the pathways are accessible. I think those
need to come to an end fairly quickly now.
Those were the key points that I was going to just pull out of the report, and just wondered if there was any questions that people would like to ask.
Happily for you, there will be. Don't worry about that. But before the members get their chance, just later, do you want to add anything, please?
Yeah, I wouldn't mind asking a question. So you mentioned the Learning Disability Improvement Programme. So there'll be a team of people that meet up to talk about reasonable adjustments and things like that. So with the Cambridgeshire and Peterborough Councils, Healthwatch run a learning disability partnership board. Do you have representatives from people with learning disabilities on that team?
And what we're going to do is take questions in twos and threes. So I'm going to ask Colleen to respond to Jess's questions in the first batch. So if you finish with any other questions you wish to put, Jess.
That's it. I just wanted to know if there was a representative, someone with learning disabilities on that improvement programme board. Yeah.
Okay, is that your question?
Yeah.
Yeah, lovely. Thank you very much. Now, for members of the public who are watching this, we have had induction training for the members so that we all start off from a level playing field. And we think about 3 R's in considering our feedback at the end of the session, where we are reassured by what we hear, anything we want to refer back because we're not reassured, and any specific recommendations we want to make. And so that will be informing the members in our questions that we wish to make. We've prepared this carefully, and we're going to divide our questions up into 3 sections. First, on access to the annual health checks. Secondly, on reasonable adjustments. And thirdly, on health action plans. Firstly, then, on access to health checks, I think Councillor Garvey is going to start us off.
How do people get on to the learning disability register with their GP? Oh, sorry. Yeah. How do people get on the learning disability register with their GPs? And how does this work? How does this work for people who receive late diagnoses? Late diagnoses.
And then the third one in this round, Councillor Bradnam, please.
Right. So the short Cambridgeshire Community Services video of a service user explaining what happens at annual health checks is informative and accessible. So do you know when this was introduced, how many views it has had, and do you think it's improved uptake rates of the annual health check? Because obviously it helps people understand that it's available to them and that they can have it.
That's the first round.
Sorry, I missed the very beginning of that question.
So it was,
Listening and writing at the same time. If you could hand these over.
It's a fair point, and members of the public will be a bit befuddled watching. This is only a guide to what we might or might not ask, and it's an internal note for the members based on our preparations. It's not a script, and so we won't be following it exactly, and it might confuse our guest if we pass it over and then don't follow it at all. So I'm ruling on that. We don't pass it over, and we've discussed this in the past with Democratic Services, and we believe that's the best practice.
But I'll repeat my question so that it's clearer. So I was looking at the short video that we were provided the link to, the Cambridgeshire Community Services video, which was talking about access to annual health checks. And it's useful and accessible. And obviously, people with learning disabilities took part in the making of it. So do you know when this was introduced, how many views it's had, and has it improved uptake rates? And has it also been used to promote to people to remind them about their eligibility for a health check? Thank you.
Thank you. So if I start with the first question around the Learning Disabilities Improvement Programme, and yes, we have got representation from people with a learning disability through Voiceability and the Speak Out Council. We had a workshop back in July, and Voiceability worked with over 50 representatives from people with a learning disability to pull together their views and thoughts around what it was they wanted from learning disability services in the community and wider. And then the work that they pulled together was used within the conference to enable us to start thinking through what improvement pathways we needed to put in place and what they needed to look like. We've also got a Learning Disabilities Improvement Programme Board this week, and the theme for the meeting this week is to work with parent carers, Voiceability, Parent Carer Forum, and a couple of representatives from Speak Out Council to try and understand how we best capture their voice across all of the different programmes of work, because there are 5 task and finish groups as part of the Learning Disabilities Improvement Programme. And we want to make sure that we are making it as accessible as possible for people, whilst recognising that a lot of meetings is quite an onerous burden on people's time, and also being able to make it as easy for them to understand what we're trying to achieve. So because health and social care pathways can be quite complex. There's lots of bureaucracy, there's lots of reports that have to be written and made available. So it's kind of, how do we make best use of people's time to inform and feel that it's properly co-produced and that we're not just doing to. So part of this week's workshop is around understanding how we can best reach out and use people's voice going forward. Yeah. The second question around how do people get on the register? So everybody has to register with a GP practice in order to get their health needs met. And as part of registering with the GP practice, they will then identify if that person has a learning disabilities diagnosis, and then they will reach out to make sure that they are offering an appointment to people with a learning disabilities. I think one of the challenges you've identified is that sometimes people get diagnosed later in life and don't necessarily always get diagnosed earlier. And then the reports will then filter through to the GP practice once the diagnosis has been made, and then they will be brought into the annual cycle of recording and reporting and letters out to them to invite them to the appointments. So that's how people are identified for an annual health check. We are doing a huge amount of work with our colleagues in the local authority in education around special educational needs and disabilities, because annual health checks are available from the age of 14, and we're working really closely with the parent carer forums and preparing for adulthood, so that at a very early stage there is recognition that people with a learning disability or extra needs can access an annual health check, and are starting on that programme from a very early age, and that enables them to make sure that they've got early intervention around their health action plans. I hope that's answered that question. And then the final question around the videos that were produced by Cambridge Community Services. My understanding is that those were made sort of off the back of the last report that we completed, where we were having some real significant challenges around people accessing annual health checks. So it was around 23-24. I have reached out to the producers of the video in Cambridge Community Services. Unfortunately, the person that has the data around how many hits they get on the video is actually on annual leave this week. So I do apologise, I haven't got an answer for you on that one, but I will absolutely get back to you after this meeting to provide that information. What we do need is that there are a lot of people accessing it, and that we have been made aware that as a result of that, it has raised the profile of annual health checks, and that it is enabling people to understand that that is something that they are eligible for, and that they need to go and get an annual health check if they don't get a letter from the GP practice advising them that they are eligible for one.
Thank you very much.
Thank you. Now, still on access to the health checks, Councillor Horgan, I know you had a number of ideas, but could you choose perhaps your priority question that you'd like to put?
Thank you, Chair. Shall I read out all three? Is that a sufficient group?
Choose the one that you think is most important, and we'll see how the time goes.
Okay. Hello. On the subject of Oliver McGowan training, I'm interested to understand how many professionals that are involved in the delivery of this service, either as an absolute number or a percentage, basically have actually completed that training.
Thank you very much. Question from me. People with learning disabilities sometimes see a doctor, they sometimes see a healthcare assistant, they sometimes see a nurse for these checks. And it's not clear from your report what's the criteria which exists on who you see, or is it ad hoc? And it is clear from the Speak Out report that some people with learning disabilities would like to see a doctor and would like to see a doctor in confidence, and that they're not being offered that. So what are the criteria, and what can you do to ensure that a confidential discussion with a doctor is available to any person with a learning disability who wants it? And just before I ask you to reply, anything else on from other members who've not spoken yet on access to health checks? Councillor Pitt first.
Thank you. I'm just interested to know, so you mentioned about a letter going out to invite people onto this programme. If that letter isn't responded to, is there a system in place that follows up with the patient?
And Councillor Bradnam.
Thank you. I'm mindful this isn't quite about access, although it is indirectly. It's the indication that one of the authorities started to call it the annual learning disability check in order to encourage more participation. But actually, I think that's a misnomer. And it was really an observation, and you might want to respond to it, that I think actually an annual health check is a more truthful and more straightforward descriptor of what actually needs to be done. So you might want to comment on that. Thank you. Thank you, Chair.
And the last one, Councillor Martin.
Thank you very much, Chair. I note in the report that we have in front of us about the pilots, or the health pilots that have been done. There's a couple in there, one being the key workers, but the other one I'm more interested in is the special schools health pilot that was put forward. Have there been any learnings that come out the back of that you've been able to then implement into standard mainstream education? We're obviously seeing in education, we're all aware about the increase in the amount of people going into normal mainstream schools that have SEND needs. So I'm just wondering how that pilot went and whether you've been able to translate some of that into a normal education setting. Thank you, Chair.
Quite a range there, please.
Thank you. So to start with the Oliver McGowan training, what I can tell you is that everybody in the Integrated Care Board has been trained on the Oliver McGowan training. What I can't tell you at this point in time is how many of our providers and colleagues working in the provider arm have had their training. This was delegated out to Cambridge and Peterborough Foundation Trust, and we have reached out to them to understand the numbers of people that have been through the training and are yet to go through the training. They haven't come back to me, so I will have to come back to you on that question. Second question, criteria around whether we should be seeing a doctor, a nurse, a healthcare practitioner, that there isn't a specific criteria for which professional people would see, but there is, it is based on need. So most practices will use a healthcare assistant to do the initial annual health check and go through the template and the standardized questionnaire. And then based on the findings within that annual health check, if there are specific needs that are identified, then they will be given an appointment to see either a nurse or a doctor to follow up on that. Is my understanding of how the process is working at the moment. That is something that I think it would be really helpful for us to actually ask more people with learning disabilities, actually, how would they like that to happen, and what is the best way for us to make that accessible for them. But they will be able to see the right practitioner for their need. It's just whether it's all happening in that same appointment is the challenge. The next one around the DNAs. So yes, there is a recall system. If people don't turn up for their appointment, then 3 more letters will be sent out to them. Obviously, there are going to be circumstances where some people aren't going to maybe pick up a letter or understand a letter, and they will be phone contacted. A lot of people also will have advocates or relatives or carers that would come with them to access the appointment, and people would be advocates and parent carers would also be contacted if we were struggling to get hold of someone to come and get their annual health check done. In regards to the naming of the health check, that's not something that we've had local discussions about as to whether it should be a learning disabilities check or an annual health check. The way we've always reported it as an annual health check, but I'm really happy to take that back into our learning disabilities improvement programme and have that conversation with people with lived experience to see whether they have a preference of whether it's called a learning disabilities check or an annual health check. My preference, I guess, would be that it's called an annual health check, because why would we want to discriminate against anybody? And actually also it does, for me, give more of a rounded indicator of actually we're looking at your health and supporting you with meeting your health needs. And so for me, that feels more accessible. But I do think that is something we probably need to test out with people with a learning disability. And then the final question about the 2 pilots. I'm disappointed to say that the pilot around the special school hasn't progressed. We did identify funding for it to start. We had got the teams all set up and ready to go. Unfortunately, with the funding restraints or constraints in the NHS and challenges with meeting our bottom line, we had to pull that funding and we weren't able to progress with that pilot. So unfortunately, I don't have any data from that pilot. But what I can say is that our teams are working very, very closely with teams in special educational needs and disabilities within the local authority and with education partners. And off the back of the SEND inspection that we had earlier on this year, and we are working to really understand how we improve uptakes of education and healthcare plans and make sure that the health elements of it are as up to speed and correct and accessible as they can be. And we are working with colleagues around the increasing demand and pressures with the significant increase in activity around special educational needs, particularly around neurodevelopmental, where we've seen a really high rise in autism and ADHD. The other pilot around key workers. That has been a really successful programme. Regionally, it's been recognised as a really gold standard programme. We have expanded it this year to include up to 25 years of age. Previously, it was only up to 18. And we have identified some really good outcomes from the work that our key workers are doing. We've got the best rate of avoidance of admissions to hospital in the region for children and for adults now, as a result of the support that the key workers are providing with that holistic wraparound care, both to the individual and the family, to enable their needs to be met more successfully in the community and prevent them from becoming at risk of admission to hospital. Our rates came down from 11 children in hospital to 2, so we're really, really pleased with that.
Thank you very much. Just to remind members, if you feel your question's not been answered or you've got a burning follow-up, do indicate and I will bring you back in. I'm now, though, going to move on to the section on reasonable adjustment. It is a jargon word, so again, for members of the public watching, these are the special arrangements to make... sorry?
I'm sorry.
No.
Martin.
Okay. These are special arrangements that are made to ensure that it's accessible. These health checks are accessible, or any other reasonable accommodation. Things like easy reading, for example. So let's take some questions on that. I'm going to invite Councillor Horgan first, please.
Thank you, Chair. Just one question in this section. Obviously, I hear a lot of work that you're doing to encourage people to engage better with the process, etc. If I asked you to just pick out, what was the one learning that you've had that's based on feedback that you've basically listened to and made some changes on? Is there anything that stood out in your opinion? It might not be, but if there was, I'd be very interested to hear what worked.
Thank you. Councillor Martin.
Sorry, Chair, when I put my hand up, it was more of a question about the process. I wanted to find out, were we going to talk about the 3 Rs after each section, or we're going to wait until the end? Because I do have a couple of things that I wanted to raise as part of the 3 Rs.
Until the end. That's fine.
Thank you very much.
I'm going to put a question on this. We're having this session today because we had a similar session on the health outcomes for people with learning disabilities in December 2023. And we said then, improve accessibility of the health checks through more easy read and more choice over venue. And the Speak Out Council has made quite clear that people with lived experience want more easy read and more choice over venue. And you've come today and said, we're exploring and we've put it in our programme for 16 months to do more easy read and more choice of venue. Why didn't you do that 2 years ago? What's stopping you actually doing that? And why, when you say you're going to do that now, what's different about the fact you really will do it rather than you'll just say you'll do it? Anyone else on access? Any unreasonable accommodation? Sorry, on reasonable accommodation. I apologise. No. Please, Colleen.
Thank you. So from the perspective around the 1 point of learning of what really works for people around reasonable adjustments, what we're hearing from people with lived experience is that it's about the environment being accessible, reassuring, having a bit more space and time to be able to not feel rushed, and so that things can be explained properly. That was very loud and clear, that came through the workshop. It's come through all of the reports that we've had through Speak Out Council, and the work that Voiceability have supported teams with. And it's also one of the things that we're hearing from our parent carer forums as well. It's that very much about being listened to, being heard, and being able to communicate in a way that makes a person feel valued. So that seems to be the key thing that's coming through, which I think is where the benefits of the Oliver McGowan programme are really helping to ensure that practitioners who sort of work in mainstream services and don't have that additional specialist learning disability training, to think through how can you communicate in a way that is ensuring that the individual in front of you, whoever they may be, understands what you're saying, and is able to feel that they can have their voice within that, and not feel that they're wasting your time. So that's the real value of the Oliver McGowan training, because it's really supporting people with understanding what's required. I think it's really difficult in health services these days because people are so pressured and rushed, and actually it's just taking that time to stop for a minute and think, actually, I need to just spend a little bit more time with this individual to help them understand. So I think that's probably the biggest learning that we've taken forward, is making sure that people are communicating effectively. The second question around the programme of work and what difference it's made. So we had a company that we commissioned called PSC, which was about 18 months ago, and that was following the last challenges around where we're at with learning disabilities, and recognising that we aren't getting it right and that it's not good enough what we're doing for people with learning disability and lived experience. And PSC came in and did a wide stakeholder workshop with multiple providers, forums, voluntary sector, including people with lived experience, and their parents and the carers, to gather a lot of information and data about actually what was working in our system, not just the health pathways, but more generally across all pathways, through health and social care and education, and came up with a list of about 500 lines of inquiry to be followed through. These were whittled down into 15 statements, which were then co-produced and tested with people with lived experience, and out of that came the 5 work streams that we are now working through to enable us to change the services and work with our providers to deliver against the expectations of what has been identified both through the work that PSC completed for us, the Joint Strategic Needs Assessment, and the Learning Disabilities Health Improvement, not Health Improvement Plan, the Learning Disabilities Needs Assessment, and the information that we've got from the reports from Voiceability and the Parent Carer Forum. And those 5 work streams are focusing on reasonable adjustments both within mainstream services and in specialist learning disability services. Crisis pathways, so particularly looking at that very high end of need when someone may have a mental health issue or may be going into crisis and is at risk of hospital admission. We're looking at the community pathways to make sure that people with things like long-term conditions around diabetes, epilepsy, respiratory are able to get their needs met in a timely way and in the right place with the right environment, so that they can understand what needs to happen. We've got a work stream as well looking at the data, the KPIs and the outcomes. We've pulled together a service specification from all of the work PSC have done, and from the workshop that was completed in July, and that is currently at the moment in draft form and being co-produced and co-tested with all of our service users and providers and stakeholders that were engaged with all of that work, so that we can then finalise the service specification, get it signed off through the new governance arrangements that will be in place over the coming months with the new ICB clustering arrangements, and we will then be able to roll that out from 26-27. We went back to ICB board last week, 2 weeks ago, because the original plan was to reprocure the services from the 1st of April. We recognise that there's still more work to be done and there's more co-production to be done, which was one of the challenges that we had in the workshop, that we needed to make sure that the voice of people with lived experience was louder and clearer, and we've gone back to ask for an additional year's time frame, with a view to putting new services in place by March 2027.
What I hear from all that is that a recommendation from December 2023 might start to be rolled out in 2026. And it's quite simple. They want easy to read letters and they want a choice of venue. And you've been told that in 2023 and 2024. Last round of questions is on health action plans. Councillor Dr. Noaz first, please.
Thank you. My question is a fairly simple one, but I do have a couple of other questions that arose from the presentation, if I may, please. Okay. The first question is, in the olden days, we used to have a metric called QALYs, quality of life years. How would you now judge the quality of the lives of people you treat and the quality of treatments you give? How and who will judge that? And Chair, the questions that I picked up from the presentation is it was mentioned that the community-acquired pneumonias and cancers and so on. Now, some of these conditions are quite apparent and easily detectable. However, conditions such as cancers and diabetes, you've just mentioned, and hypertension are a bit more insidious and they can do considerable harm in a year. So is it possible to institute measures for more frequent checks for these? Secondly, I think you mentioned in passing about mental health. I think mental health is a very important issue. We are now having sort of an endemic or even epidemic proportions of health issues, and I will get onto this later in a different section. People with learning disabilities, according to some studies, are twice as likely to face mental health problems, issues, and crises for a number of reasons. And I would like to know what measures you have in place for these assessments, assessing these people. Similarly, the sexual health of people with learning disabilities is also proportionately greater among that section compared to the general population. So what provisions do you have or can you make to carry out more frequent checks and tests for diabetes, hypertension, cancers, as well as for detecting any underlying mental health issues and sexual health issues? That refers not only to STIs, but such things as unwanted pregnancies and various other issues, abuse and sexual abuse and so on. What measures do you have in place and what would you suggest? Thank you, Chair.
Thank you. I appreciate there was a lot there, but I'm just going to squeeze in a couple more. Councillor Horgan wanted to come back, but just are there any other members who've not spoken yet who want to ask a question on the annual health checks?
The health action plans.
Okay, Councillor Horgan.
Thank you. I'll sort of roll two halves of a question into one, if I may. And it's about screening for common comorbidities, e.g. epilepsy, dysphagia, mental health conditions.
Speak into the microphone,
Yeah, sorry.
so that we can hear.
Yeah, probably better if I put it over this side. I can look at you at the same time. Yeah, so it's the screening for common comorbidities, epilepsy, dysphagia, mental health conditions, and obviously, I guess the question is first, do you do that, and what steps do you take to do that? And then the second part is how do you avoid diagnostic overshadowing where symptoms are wrongly attributed to the learning disability? Thank you.
And final quick one from me. I'm sure you've seen from the Speak Out Council report, half of people with learning disabilities aren't getting health checks. And of the half that are, some of them are just told to fill them in themselves. So this does seem to be an area of concern. So it's only fair to ask you to put on record your response to that. Colleen.
Thank you. So I think I may have caused a little bit of confusion when I was talking about the timeframes. The timeframes were specifically around the longer piece of work for the Learning Disabilities Improvement Plan and wasn't specific to the annual health check. So apologies if I caused some confusion about the two pieces of work. Annual health checks has been significantly improved since 2023, and we've definitely seen an uptake in the number of annual health checks that people are being able to access. So apologies if I caused some confusion there. So the first question around who judges the quality of that, was that the quality of the annual health check? Sorry, I didn't quite understand the question.
Yes, the quality of these tests, these examinations, their results, and subsequent quality of life of these individuals. Thank you.
Okay, thank you. So we have a primary care contracting team that do quality assurance visits of all of the primary care practices, and they will make sure that they are reviewing and auditing some of the annual health checks to be able to get that quality assurance process in place and make sure that they are of a standard that they should be. So that happens as part of the natural contracting process and contracting round. And then that's fed back into our governance processes and board reports around the quality of those annual health checks. If they are concerned that the audit is showing that those are not of a high standard or a high quality, then they will work with individual practices to ensure that they are improving their standards within how they carry out their annual health checks. So that's carried out through the primary care contracting team. The next question around how can we ensure that there are more checks, around some of the more complex conditions like cancer, hypertension, which we recognise can go undetected for many years and then have some serious comorbidities and long-term consequences, as well as things like diabetes. So as part of that annual health check, that they will have their blood pressure taken and they will have a check for diabetes. If it's identified that there is a blood pressure issue or anything around diabetes or pre-diabetes, then they will be pulled into a recall program to ensure that they are getting more regular checkups to monitor stabilising the blood pressure or making sure that they're accessing the right diabetic services to enable them to get proper follow-up until the condition is stabilised, and then they will get the annual follow-up to make sure that they remain stable with those conditions. From a mental health perspective, we do have a specialist learning disabilities team for people with lived experience that are suffering with mental health. And that has been one of the key things that's come up in the Learning Disabilities Improvement Programme, that's an area that we absolutely do not want to lose, that specialist element around mental health support to people with a learning disability, because of the nature of it being more complex, and that is not something that we would want to absorb into our mainstream mental health services, where people aren't trained in understanding how to adapt their style of communication and ways of working to support people with a mental health. So we are really keen, as part of the crisis pathway work, that we are maintaining that real specialism for learning disabilities around accessing mental health. From the perspective of sexual health, we as an ICB do not commission sexual health services. That's through public health. So I can't speak for public health, but what I can do is that we will, as part of the annual health check, there is questions around contraception and if people are accessing sexual health services, and signposting to those relevant services. And what we do know is that as part of the SEND programme of work and the educational system, that there is quite a lot of sexual health education taking place, particularly in special schools, because we do recognise that there is a bit of a misnomer that people with learning disabilities don't have sexual health issues, but actually they do. And the same goes for screening around cervical cancer. So we make sure that as part of the annual health check that they have had all of their screening, whether it be for cervical cancer, bowel screening, etc. All of the screening that is accessible by that is open to everybody is accessible to people with the learning disabilities. We wouldn't discriminate in that way. And the question around screening for epilepsy. So that, once again, that's one of the questions of the annual health check, to make sure that people are asked the question around epilepsy. And then if it was deemed that there was identified needs around epilepsy, then they would be followed through the epilepsy pathways to make sure that they were supported with any challenges they may face around epilepsy and any requirements. How to avoid diagnostic overshadowing. So that's a key part of the Oliver McGowan programme, because it has been recognised, certainly through lead reports in the past, that there is still challenges around diagnostic overshadowing because of the inability for people with lived experience to necessarily communicate their needs effectively. And it goes back to our earlier discussion about actually really making sure that the communication is absolutely right and that people are given the space to understand, be heard and listened to, so that we are really focusing on making sure that we've understood what the needs are and that we aren't writing it off as something else because of the person's potential learning disability or challenges that they're facing. So that's why the Oliver McGowan programme is absolutely critical, that we get that out to all of our providers and clinicians out there, and our education and care staff as well. The final question was around the I'm really sorry. Would you be able to repeat the final question?
Half of people with learning disabilities don't get annual health checks.
Sorry.
And of those that, as annual health action plans, thank you very much. Action plans, and several of the half that do are just asked to fill them in themselves.
Yes. So whilst we have been increasing the number of people accessing annual health checks, there is also a focus on making sure that as part of that annual health check, people are getting their health action plans completed. So we should start seeing an increase in the number of health action plans that people are getting now that we're getting better access to annual health checks. It's all part of that process.
Thank you very much. We've overrun a bit, for which I apologise. Just to Councillor Martin, what happens now is I'll summarise some of what I've heard. I will then give a chance to any member who really feels there's a sort of burning thing that I haven't covered to speak. And then what happens is that Rashenda takes the recording of the summary with her own notes. She draws up the recommendations from that, and then she agrees them with the Vice Chair and myself, as long as that's acceptable to the committee. That's how it's operated in the past, and it's enabled us to have clear and coherent recommendations rather than just cobble them together at the end of the meeting. So if you and other members are happy with that process, that's how we would intend to do it. What I've heard that there is an understanding from the ICB about the importance of health checks in early intervention, that they're critical to improving the life chances with people with learning disabilities. I think we would want to agree with that and support them in that view. We've heard specific questions about the importance of increasing take-up of cancer screening, or mental health and of sexual health support where required. And I think we'd want to be insistent that is checked and double checked, that that's being done. I think we would want to welcome the increase that has happened in terms of registering people with learning disabilities and increased take-up of numbers. But I think there was a genuine difference there in that an increase in numbers is great, but the quality remains an open question, and particularly in terms of reasonable accommodation. I think we're listening to the experience of people with learning disabilities themselves. We'd want to encourage the ICB to do much more in terms of easy read letters and choice of venues in particular. We've heard concern about the terminology annual learning disability check, but you've said that you've heard that for the first time, and you will take it to your mechanisms for consulting people with lived experience. You said that you will that you will come back to us because it's not available today on the take-up of the video that's encouraging the health checks, and also the take-up and targets for Oliver McGowan training with providers rather than with ICB direct staff. So we look forward to receiving that. I think we said we underlined that it was important to have a right of a person with learning disability to see a doctor if they choose for the check, which is slightly different from your approach at the moment. I think we've heard there was concern about failure to go ahead with the pilot in terms of special educational needs schools. I think we would probably want to welcome the positive results on reducing avoidable admission to hospital. I think we've heard at the end there a very clear commitment towards increasing the number and quality of health action plans. We hope that you've enjoyed the last hour and 10 minutes or so. We've certainly learned a lot by doing it. Thank you very much for coming, and that closes this part of the questioning. I see our next speaker, Louis Canfer, is here, old friend and colleague, but to avoid having a break in the middle of his session, I'm going to suggest we have a maximum 5-minute break now, so we come back at 16 minutes past 3 if anyone needs a comfort break. Just give me a second, there's one more point. Councillor Martin.
Thank you, Chair. Completely agree with all the points that you've raised. Just another couple of points that I picked up during the initial statement, as well as some of the questions. I think it'd be useful for us as a committee to understand who takes responsibility of what, particularly when it comes to things like the Oliver McGowan training, because it sounds like the data is being kept by the ICB doesn't tell you that the people that are administering the tests and are fully trained. The ICB doesn't have that data, so it'd be useful to find out who has that data and why the ICB doesn't have that data, considering the ICB are the ones that are commissioning the services. But I think that goes into a broader point about the data. How is the ICB keeping on track and keeping an eye on what is being done, how it is being done, what reasonable adjustments are being held, are being given, and why in some cases they're not being given. I know in the opening statement they said about data not being good enough. I would like to see coming back to us how the ICB are going to improve that data collection and giving us an opportunity to scrutinise the ICB and the individual trusts to work out how they're going to work better together so we can be better satisfied in the future that this is being done and that we're maximising the opportunity that there is here to get these health checks completed.
Okay, I'm very happy to endorse both of those points from the chair. And I think the last one, obviously you could answer now, but I'm afraid we've hit time limit. But I think asking how you hold data and how you're going to improve that, if that could come in the form of a further communication following the meeting, would be really, really grateful. Any other member? I did overlook that and I apologise. Councillor Dr. Nomas.
Thank you. Coming back to my original question, with reference to these more chronic conditions such as diabetes, hypertension, cancers, and not so much chronic, the STI. I would feel much happier if these tests, because of their potentially multiple pathologies and high morbidities, could be done more frequently than just once in a year, because they are very simple, very quick, very cheap, very cost effective, and save a hell of a lot of money in the long run. Could we do that, please?
Okay, and again, thank you for that. I'm going to endorse it from the chair. So again, if that could be part of a follow-up communication, that would be great. And I think that the point about mental health screening, sexual health, cancer screening was well made during the session. But I think that specific point is, could it be more than once a year, is a very interesting question. And I invite you to come back to us in the follow-up. Any other member? Are people happy that we follow that procedure, that Rashenda takes the available information and turns it into recommendations? Everyone happy with that? Okay, in which case I'll take the 5-minute break now. If we could be back in our seats at 19 minutes past 3. Thank you to Colleen very much for being with us.
Thank you.
And I invite Louis to take his seat at the table.
Thank you.
And would everyone like to take their seats, please?
Not Cora yet. You just wait. 1, 2, 3. We Cora, but we're missing the bit. I think I'm gonna go to the notes.
So, welcome back. Item 5 is the delivery of the NHS 10-year plan in Cambridgeshire, and we're joined by Louis Camphor, the Executive Director for Planning, Strategy and Evaluation at the Integrated Care Board. A separate scrutiny session is taking place in December on the implications for the Cambridgeshire Integrated Care Board cost reductions and reconfiguration, and we're keen that today's session should focus mainly on what difference the 10-year plan is and will make in practical terms for Cambridgeshire's residents. But of course, there's likely to be some overlap. The committee appreciate that these changes are happening at pace, and we see this session as a first step in engaging scrutiny in this process in what we hope will be a constructive way. As before, we're going to assume that everyone has read the report carefully and to ask Louis to introduce it briefly to then enable us to move to questions. Louis Camphor, you're very welcome.
Thank you very much, and thank you for having me. I'll take the report as read, as you say, and just say, first of all, maybe that at this point in time, obviously we are still expecting quite a lot of guidance in terms of the expectations around the sort of 5-year plans that are referred to in the report, and we are also still expecting multi-year settlements to be published. So there's quite a lot of things we don't know at this stage. But as you say, in the 10-year plan, it very clearly sets out sort of 3 key aims, which I'm sure I don't have to repeat, but it is hospital to community, digital enabled and prevention focused. It really emphasizes integrated neighborhood teams. It really emphasizes digital transformation, and it very much emphasizes a unified patient record with a focus on health inequalities. We've got a framework published on the 8th of September, and it very much asks us to do 3 things, essentially. We've got to, as commissioners, develop a 5-year plan, commissioning plan. We've got to provide a set of provider plans, integrated provider plans, so also on a 5-year time frame. And we've got to produce neighbourhood health plans, which will be overseen by health and wellbeing boards and drawn up by local government by working closely with other partners, including health, obviously social services, the VCSE sector, etc. I think it's important to say that as part of that sort of planning and as part of the 10-year plan, I think we've previously had discussions here around the work that we've done locally with our North-South partnerships and our integrated strategy and our strategic commissioning plan. And you'll remember that we talked quite a lot as part of that plan on what we think we should be doing in terms of digital enablement, a managed care approach, a big focus on health prevention and optimization. And so I feel like as a system, we've got quite significant foundations already that's very strongly aligned to the 10-year plan that we can use in the next phase of our planning to make sure that we robustly move that forward, essentially. So we're not starting from a blank piece of paper, I think is really important to recognize. So the papers also talks about how we would approach this as health. So it talks about sort of our planning process, the fact that we'll focus very much on the population health, population needs, talks about strategy, and it talks about the technical planning side that we're working through. And we're also obviously working closely with colleagues, including Sally and Patrick, on the planning, and we will be doing lots more engagement as the plan developed. Engagement obviously is critical, and we'll continue to focus on that. But essentially, I think it's a bit of an update about a plan that we're about to embark on. But by December, we would need to have our sort of strategic plans ready for the next 5 years. In between now and December, quite a lot of work will be happening on that. Over the next week or so, as a commissioner, we'll be publishing our strategic commissioning intentions. And I'll talk a little bit about that in a second. Just setting out in draft form what we think the highest priorities are and what we'll be doing around the 10-year plan. And then, as I said, the sort of 3 plans, I think the biggest challenge for us will be making sure that our ICB strategic commissioning plan as well as our integrated provider plans, as well as our integrated neighbourhood team plans, all fit together and sort of talks around the same future. Because I think the danger here is that we go off and do things in silos. And I think the whole intent behind those plans is to bring our system together so we use everything that we've got to work together for the best of our population. We've already started to do some work on our population priorities. And as you know, I'll talk a little bit about the fact that we've been brought together as a 3 ICBs across Central East. We've been doing a bit of work to understand the population needs, understand our health utilization and what's driving that, and understanding where we've got key assets already and big programs of work that we could scale. And as part of that work, and I've shared this with Sally already, we've identified that the 5 sort of key programs for us to focus on will be mental health, cardiovascular disease, cancer, advanced illness, and respiratory as the sort of 5 key themes. But we'll issue those in draft form probably in the next week or so. It's going to our board on Thursday. And then we will be continuing to engage on that as we move over the next 3 months and as we bring those plans together. The reason for picking those areas is when we look at health utilization, they're the biggest things that stand out, but they're also one of the biggest drivers of health inequalities in the system. And so we feel those are the right areas given the complexity of our patient cohorts, and actually also if we bring the Central East ICB together, that stands out as the key priorities. So at this stage, commissioning intentions next, then draft plans, lots of engagement over the next 3 months. And as I say, our big challenge is to bring the plans together in a way that they all align. And some of that work we've done through health and wellbeing boards, some of it through the ICB boards, and some through provider boards. And so I think the challenge being that it all links together at the end before it goes to scrutiny centrally. But I'll stop there. Hopefully that's a quick canter through the paper, and happy to take any questions.
Thank you. And again, I'm sure there will be. We'll take it in a number of rounds. It'll be 2, 3, 4 in each round, roughly. So grateful if you can take notes as each questioner speaks. I'm going to start with one of the shifts from hospital to community. And Councillor Bradnam is going to be first.
Thank you, Chair. And thank you very much for your report, Mr. Kaffner. So you've said in the report that one of the, you've got your 3 shifts and that one is from hospital to community-based care. But I'm just wondering how that will be delivered in Cambridgeshire and what it will look like. And also, communities may not be ready to take up that challenge of the movement of money from hospitals to community. And I'm hoping the money travels with the work. So how will communities be engaged and supported? That's my first sort of little cluster of questions. And the second one is inevitably in a move to community, that's going to need to involve the voluntary services. So I just wanted to ask, how will the voluntary and community sector be engaged in this shift to community-based care?
Councillor Horgan, again, if you could choose the priority from amidst your questions.
I think that's quite easy, actually, because Councillor Bradnam sort of asked my first question for me. That's not a very efficient.
Great minds think alike.
My background is computer science. So obviously I'm particularly interested in how things like AI, data analytics, digital health tools play in transforming the services.
That was short and sharp. And in this round, I'm also going to ask Jess Slater to come in.
Thank you. I've got a specific question around this. So the NHS planning framework and the national 10-year plan sets out a clear vision from hospital to community. It's built around integrated, local, multidisciplinary teams, so I've read it, the voluntary sector and personal support closer to home. In that context, Cambridge University Hospital's decision to remove voluntary sector funding from, I was going to come with for rank hospice, doesn't seem to align with those integrated care closer to home principles. So my question is, what accountability mechanisms are going to be in place to ensure that decisions by individual NHS providers do not undermine the system-wide commitments to neighbourhood-based, closer to home care?
Great question. And the Rank hospice issue has obviously been quite sensitive in the last period. So I will just say, does any other member want to add to specifically that question? Yes, please, Councillor Pitt.
I would like to, but I'd actually like to hear the responses to the first set of questions because they overlap somewhat. So if I could come back at the end of this section.
That's fine. Okay, so I'm going to ask one more member in this round, Councillor Martin, please.
Thank you very much, Chair. And part of the 10-year plan, obviously, it talks about the moving from hospital into the community, and part of that's going to be to do with digital. So it talks about in your report about the NHS app, as well as a unified patient record system. Now, two of the trusts in Cambridgeshire and Peterborough, or within the Cambridgeshire and Peterborough footprint area, have two very different systems and on different ends of the scale. So some of you may be aware of HIMSS, which is the Health Information and Management Systems Society. They have a ERAM, sorry for all the abbreviations there, which stands for the Electronic Medical Records Adoption Model, which is ranked on a 0 to 7 scale. Now, one of the trusts within Cambridgeshire and Peterborough is quite high on that scale. The other one is very low. My concern is that with this move, that we could end up having a disparity between parts of Cambridgeshire and other parts of Cambridgeshire, depending on which trusts they're looked after. So I'm wondering how the ICB think they're going to be able to cover that gap and try and make it so it's an even keel, so it's not a postcode lottery on whether you have to go to hospital or whether you can be treated within the community.
Plenty for you to chew on.
Thank you. I think I'll start by saying, as we're sitting here today in Cambridgeshire and Peterborough, by 2040, we will need 900 extra hospital beds to cope with our population's aging. I'll also say that when you look at our data and our information that we hold, there is a significant amount that we can do to modify and to optimize the risk for patients in a way that means that they don't need hospital beds because we can prevent things like strokes and heart attacks. We also know that 35% of our bed base is occupied by patients in the last year of life. For some of them, it's unavoidable, and for some of them, unfortunately, there is no other option. But for a large proportion of those patients, that's not where they want to be, and actually they don't necessarily need to be there. Something has failed them in the community, and that's why they ended up in hospital. And I don't want to make this about hospital beds because actually that should not be our focus. The whole point of the 10-year plan is to move us away from having a focus on hospital beds, but it is a really helpful indicator to use to drive the conversation that we need to have about out-of-hospital services. If we use the same modeling to forecast forward by 2040, we would need to do a significant amount of extra work in our community services. The same would apply to social care and other services that local authorities have, as well as all our health services, be that GPs, mental health, community provision, in order to stand still. We then need to work out how do we enhance that so that we save the 900 beds. So standing still is going to be incredibly difficult over the next 15 years. And we need to make sure that we do more than that because there's a relationship between about 10 community contacts save a hospital admission. So there's a relationship there. The other thing that we're playing against is a workforce issue in the country, not in the NHS, in the country. So when we are seeing a very significant increase in our demand because of our aging population, we will not have the workforce to carry that burden because our workforce over the same period is going up by 13%. over 16 years is our prediction at the moment. So all of those things lead to needing a very, very different model of care in order for us to be sustainable in the next 15 years. And I think that we've got 3 to 5 years in order to make the right shifts in terms of how we do that care model, because in 5 years' time, that demand will already start to hit our services, and it's not just a health problem. So the reason I put that context right up front is I can't sit here and say it's a single thing. I can't say this is exactly how we think the community services will look like. This is what the out-of-hospital care would look like. What I do know is that the point of our integrated neighbourhood team and our place-based partnerships is that our patient feedback is really strong. We've got to dissolve our organisational boundaries, and we've got to work together to optimize our patients in a way that they don't need the follow-up care. Because at the moment, what we've got is an inefficient system where patients are being handed over from one side of the system to the other side. It doesn't work for them, and it doesn't work for us, and it's incredibly inefficient. We also know that we're not maximizing those risks that I referred to earlier. So there's an enormous amount of risk sitting in the population in terms of perfectly preventable things. One of the questions that we had earlier with the previous speaker, we're not maximizing. And so what we need to think about is what is the right model of care that enables us to prevent, enables us to optimize, and enables us to smooth the patient journey and give our patients ownership and access and options in a way that we haven't before. And that talks to your point around digital as well. So in our strategic commissioning plan that we talked about before, we set out a vision for that. Now that we're a Central East ICB, a much bigger footprint, we need to work through, does that look like the right model? And is that what we're really going to go for? And how do we implement that at an individual level? But I think it's really important that we just hold on to some of those challenges that we'll be facing as well as thinking about the future. So if we then come back to the question, so how will the care be delivered? At the moment, there are, as I said, I don't want to labor the point around optimization, but I know that there's a significant amount of risks in the population that we can change. We know that there's a significant amount that we can do about prevention. Our challenge with that will be, how do we do the prevention alongside everything else that we need to do? Because that's always the challenge, isn't it? Is the sort of financial flows and making sure that you do the prevention whilst you also recognize that that's going to pay back in 3 to 5 years' time. So we need to get out of the short-term 12-month cycles into the 5 years and do the right thing for the population. We've done already a significant amount of work in our integrated neighbourhood teams and our place-based partnerships by engaging our communities, engaging the VCSE sector, engaging our patients. And as the blueprint outlines, our neighbourhood team working is going to be so fundamental to that future model. And what I mean by neighbourhood team and place-based working, as I said earlier, is dissolving the organisational boundaries. But also, if we think about it, there is the outcomes that our patients achieve is so different across our population, and the needs of our patients are so incredibly different that our integrated neighbourhood teams has the best chance to almost penetrate those populations in a way that we are not doing before. And I can give some examples on that. On the digital element, when we looked at a local sort of development of a digital front door, and we're now in conversations with the NHS app, they very much want to really target prevention as one of their key elements, and in a way that they could work with patients on optimizing their risk in a way that they haven't before. So one of the things that we want to do locally, and the NHS app is now doing, is working with patients on their individual risk score, telling them why their risk is high for example, a heart attack or a stroke, and working with them to optimize that in a way that gives them the right information, tailoring that information to them as an individual, and addressing it. And if you think about the capability that we've got as a public sector, essentially, the more we are able to combine our information so that we can assess the risk for an individual, and the better chance we've got to intervene on that. So that's a really different thing that we can do in the future world, that we haven't been doing that successfully in the past. And we've got some really good examples of where that has worked. So we've got a high intensity user program, for example, hosted by the council that's paid some really good results. We've got a CVD optimization program funded by public health that shows us some really good results. So with a number of proof of concepts that really demonstrated this way of working is possible. But the other thing that I think digitally we need to do is give patients access to their records. We need to be able to offer patients the opportunity to book appointments when it suits them, not when it suits us. Like rather than writing to a patient saying you need to show up at 4 o'clock, we need to say when does it suit you, allowing them that, allowing them more information, more options about how they navigate their pathways and their journeys, and give them the right information, the options available to them. There's so much that we can do digitally, and we always talk about digital exclusion, which is absolutely fundamental, and we need to think about that. But we're not closing access. We're not saying to patients you can't call a GP practice. What we're saying is we want to enable those patients who want to take control of their healthcare journey to be able to do that. And so if you look at our, I don't want to labor the point on digital, but if you look at our digital landscape, it is really fragmented. And to the point earlier about what providers are offering, the one-to-one relationship between the patient and the provider quite often works, but it relies on the patient having an application like MyChart or in their phone. Then we ask them to also download the NHS app in their phone. Then we may ask them to download Ask My GP because it's another access point. Then we might ask them to download a health and wellbeing app because it's another thing that we want them to do. And you could easily end up with 5 or 10 different applications on your phone just to navigate your healthcare journey. That isn't right. So what we need to focus on is how we integrate through the NHS app all these different components, use our data capabilities to be able to make that available to the patient so they understand what's happening to them, why it's happening, and what their risk factor is, and then enabling them to take control of their healthcare journey. That's fundamentally what our vision is for digital. I'm not sure I've answered the question, but hopefully that's a starting point.
It's inevitable that we won't 100% answer every question perfectly. Members can always come back if they feel they're not answered. But I did say to Councillor Pitt that he wanted to come back on.
Thank you, Chair. So I think my question relates to Councillor Bradnam's question about what is the impact and what are the realities. I'm very mindful that we're not scrutinising the 10-year plan in itself, but actually the delivery, the implementation of it. And I think that's correct. I mean, essentially, the ideals I completely agree with. So perhaps this might turn out more of an observation, and I invite your comments on it, really. I was slightly unnerved by your mention of dissolving organisational boundaries, because I think every large organisation likes to think that they can do that, and it rarely happens. Most of the big corporations I've been involved in struggle within their own silos to kind of break free of them. But I was quite impressed at the way you navigated 5 questions at once. So I'm encouraged by your ability to break down those silos today. So I think, so for me, I'll try and keep this as brief as I can. So within my family, we've had regular engagement with Addenbrooke's, and I find that we'll have 3 people have half a day out of work and school for a 2-minute appointment. And that's obviously very inefficient for our family, but it's really efficient for the hospital. And I see moving into communities great for us, terrible for the NHS and the cost, because you can't put the onus on the NHS can't absorb that cost. But I think the opportunity for community-based care is around prevention. And so that's going to be a kind of a new strand of work, or a much expanded strand of work that will require some change anyway. And then this community care can respond to that, because the prevention is something that people won't book in for a prevention appointment at Addenbrooke's and take half a day off work. But I think that's a real opportunity that you can maximise the benefits. And my question was going to be around the timing, and you mentioned 3 to 5 years, which feels ambitious but realistic. And so I'm really concerned about actually what's going to happen on the ground. Are you going to be having new buildings in our market towns and cities, or even in our villages? Is it going to be hiring existing community buildings? Those existing ones have their own kind of natural churn, and actually they need 1 or 2 years. They'll be delighted to have some regular income from the NHS, but they'll want to know well in advance that that's coming down the pipeline, so they can start to think about how they'll fit that in. So I guess that's my question. How far are you looking ahead in terms of the on-the-ground practicalities of rolling out this neighbourhood-based care?
Thanks. And just to add to that, I don't think I did hear an answer to Jess's question about accountability mechanisms using the Arthur Rank Hospice example. And as Healthwatch has come up, can I ask Healthwatch, what are you saying to the ICB and to the local authority about your future? And can I ask the ICB, what are you saying to Healthwatch about what you're going to do to ensure patient representation and complaints management continues to be dealt with in an independent and empowered way. I'll ask Healthwatch to answer that first, then I'll move to Louis on both sets of questions.
Yeah, of course. Thank you. So I've had an informal discussion with ICB CEO, and I've met with the executive directors of both councils recently. I would say those discussions probably need to be accelerated. The Secretary of State for Health and Social Care has been very clear that the Healthwatch functions are expected to transfer into ICBs and into local authorities. I don't think both organisations know exactly what our statutory functions are. I do. It's quite a big amount of work, in particular our information and signposting service, where we have several calls every week about signposting and getting people to the right services. So I think that the transfer and what that looks like those conversations need to happen early, and they haven't yet taken place. The date for closure could be as early as October 2026, so a year's time from now. Even though it's not been confirmed, we are planning around that time. Certainly when you're looking at redundancies, for instance, for staff, you're looking at 3 months, so that's end of June. So conversations certainly need to happen before then. But we are keen to work constructively with both organisations, Peterborough, Cambridgeshire councils and the ICB, to make sure it's planned properly, but more to avoid gaps in public voice. So having mechanism, and we can help you do that. We can help you put those functions in place if we start having those conversations sooner rather than later. And I appreciate you're like running 2 organisations at the moment in that respect, because you've got Central East and also current CMP, ICB.
And so 3 questions. Obviously, the one there about the future of Healthwatch and what the ICB is doing, but also Councillor Bitt's question about community readiness and the need to advance that, and also the earlier question about accountability when decisions are taken, acute versus community. Louis.
I was just just reflecting on those questions. So I think the experience on the sort of time off and traveling to a hospital for an appointment that may or may not be worthwhile you're traveling for is sadly a common one, and I think it's something that every person in this room probably have experienced. When our vision for the 10-year plan is essentially that the reason why I'm a little bit hesitant on the detail is we've set out in our strategic commissioning plan that there were 4 things we wanted to do really well. One was digital enablement, one was optimization, one was urgent care and how we respond to patients that may be deteriorating and in need of urgent care, and the other one was sort of advanced illness and end of life. We've set out in our strategic commissioning plan, which is in the public domain and sort of signed off by the ICB back in January, that we feel we needed a very much a managed care approach, which enabled us patients digitally to kind of engage with it, but also through other mechanisms, but that we would use that approach to do optimization and prevention at scale. So if we can see in the data that we've got, I think, something like 200,000 patients across the east of England with a blood pressure higher than 140, we need to really go for that and turbocharge that. But we also need and engage with patients. And if I can just use that as a simple example, because it may help to crystallize. What we're doing at the moment with our CVD prevention pilot, which public health are very much involved in, is we are using our data to identify risk factors that are modifiable. We are then talking to the patients to say, we've got a number of indications that says you may have high blood pressure. I'm going to use that as an example. We are then talking to the patient to understand a little bit more about their circumstances and the risk that they're facing. We are then able to field them with information about the condition so that they feel informed, but we can make that available in any one of 200 languages. So already that gives you an advantage because you're not just saying this is the only one way to do it. But it also gives us the ability to say, actually, what are your circumstances like? So do you work shifts? You know, do you have a family? Can you go to a pharmacy and give us a blood pressure check, or can't you? You know, so we understand more. We're not just saying you need to show up at this time, end of. And then what we're able to do is work with them. And if they need remote monitoring, we've got the capability now to do someone's NHS health check in their house. You don't need to actually go to a GP for that anymore because most of those components is available. You can send the blood pressure machine to someone's house to optimize them. If you think about health inequalities and you think about the barriers that our patients are facing to access care, the capabilities that we've got now, both from a data perspective and from a remote monitoring perspective, is significant. So you could use that to optimize the risk. But part of that sort of approach that we've set out, we also wanted to do a lot more on referral management to make sure that when a patient shows up, hand-holding patients much more to make sure that when they go to an appointment, they've got everything that they need by the time they get there. They understand why they're going, and we're not wasting appointments along the way, or we're not asking people to travel and take time out without, you know, allowing them to understand why that is necessary, because I think we do that quite a lot. And so there's these different components that we started to pull together that we want to implement over the next 3 to 5 years that we think will make a very significant difference to health utilization. And then as part of that, how we use our integrated neighborhood teams in a much more targeted way. So saying, look, this is what your data suggests, this is what your population needs. These are the patients that we need to optimize. That's going to be really important. And if I step back from it to your point around the state and what we use our money for, using sort of health economics and other methods to say, actually, we've got limited resources, we've got limited capital. We really need to understand where we need to invest. It's going to make the biggest difference to our population. The biggest difference to our sustainability is going to be really important. So it's all part of the sort of the same thing, if that makes sense, because we're never going to have enough resources. We've got to really be careful about how we use it. And we've got to make sure that we do the right things in terms of prevention, but also navigate care differently so that we don't waste resources on appointments and things that isn't necessary and we could have avoided, or we could have done virtually, or we've got it done closer to home. So it's a really complex picture, but I think the 10-year plan outlines the key fundamentals, and I think absolutely the right direction of travel, but we need to work out how we execute that locally through our integrated neighborhood teams, and the practicalities is what we'll be doing in the next 2 months and setting that out over the next 5 years. And I just wanted to pick up the point around the EPR, which I haven't answered that either. So that the point around the existing inequity between the providers is very much on our risk register, and we understand the implications of that, because none of this will work unless we can actually lift all providers up to the right level. And so we're working very closely with that trust to try and find solutions from a capital perspective and a revenue perspective in order for them to get the agreement to get the EPR replaced, because it's a really big risk for us going forward.
Clarify what you mean by EPR?
Electronic patient record. So these are the systems that sit in hospitals. And so Addenbrooke's has Epic, for example. SNEFT in Suffolk has just gone live with Epic. But we have NWAF in a position where their EPR isn't fit for purpose and do need work, and we are working with the trust on that. And then on the point on Healthwatch, I think, you know, we very much recognize the significant benefit that Healthwatch has brought us. And, you know, it's a national decision. It's not a decision the ICB has made, but we're also recognizing the risk of that continued patient engagement. I think we're working very closely with yourselves in Healthwatch to understand how we best mitigate that and what we need to have in place in the new world. But it is very much recognizing the value as well that you've brought to everything that we've done. I think that the formal complaints procedure is still in place from a patient perspective, but Healthwatch was much more than that, wasn't it? It wasn't a formal complaint. It was actually helping us keep the finger on the pulse with the population to understand what was important to them, what was driving their concerns, what they were worried about, which was incredibly rich and helpful for us as commissioners. And so we'll need to continue our dialogue to work out how we best mitigate against the risk of health watch being abolished.
And that earlier question, which is if a trust takes a decision which is favouring acute over community when perhaps they shouldn't do, what accountability mechanism is there?
So we have to hold our providers accountable for the outcomes that they achieve. And that's going to be fundamental as we move over the next 3 to 5 years. More and more will we want to make sure that our place-based partnership are delivering outcomes, not activity, and that we're doing the right things for patients, we're achieving the right outcomes for them. The decision that we're referring to is a decision that Addenbrook's board has taken to serve notice on the outrank beds. It's got nothing to do with the ICB. It's not an ICB decision. I completely understand that the point and the optics of the decision and how that may look, and it may appear to be contradicting the direction of travel that we're all talking about. But it is for Addenbrooks to assess their capacity and their need also in the context of very, very difficult financial pressures that they are facing. But what we would be doing more and more of as an ICB in the blueprint in the future is to say, we are holding you to account for your outcomes, and how you achieve those outcomes sits more within the provider sector and over time in our place-based partnerships.
Okay, I think that's as far as we'll get today. But I did hear you earlier say that you thought people should have more choice about not going to hospital if they choose not to during end-of-life care. And I think that's an important part of the same subject.
Agree.
To members, I'm going to just jump a bit and move us on because I want to make sure we get through as much as possible. So I'm going to move to the workforce issues because Louis in his earlier answer did talk about the workforce challenge, and ask Councillor Dr. Nawaz to start on that, please.
Thank you. I'm afraid, Chair, I have allowed a number of questions to accumulate during those deliberations. I'm sorry for that, but I may take a couple of minutes. Thank you for coming and for your presentation. I realize that this is at kind of ideas stage, really very preliminary stages, and some old ideas repackaged and some new ideas. Nonetheless, I found it rather fascinating read. I thought the neighbourhood health centre plans were taken from Lord Darcy's earlier report he did a few years ago, but obviously not kind of implemented as such. My initial concerns are about the staffing and the financing. I had hoped that the government would take, and I welcome the government's initiative, and I'm kind of excited for it to unravel. The financing of it, there would be some kind of paradigm shift. There's nothing new there. It's just taxpayers' money. Take it with one hand and give it to the NHS with the other. But I'm not going to go too deep into it because I believe the chair has his own question on financing. So I leave at that. But isn't it a question of demand and supply, really? Demand seems to be outstripping supply and the availability. That's the age-old question. And this is reflected in the availability of staff to deal with burgeoning caseload, clinical caseload. And it is said that there aren't enough GPs available with a particular reference to accessibility to primary care. Now, I dispute that. My dispute is a factual one, and I would refer you to the British Medical Journal and some of their articles they refer to, and to the BMA. If anything, there is excess of GPs. The question I would like to be answered, and probably not by you, you may not be in such a privileged position, is why is it that a lot of GPs either choose to work part-time, work locum, or just leave the NHS, and worst still, leave the UK to go to Australia, New Zealand, and Canada. So there is not a shortage of GPs. The fact is, the NHS chooses not to employ the available GPs. The reasoning may be financial. I think more than likely it is. And that needs to be addressed appropriately. And I would like to draw your attention to, in particular, the shortage of psychiatrists, and in the orthopedics, as well as in the emergency care. Now, you have, and may I refer to, again, to a report in the British Medical Journal. What it is saying is, just to illustrate my point using a real information, that for the 16 to 24-year-olds, the common mental health condition has risen from 18.9% to more than a quarter, that is 25.8% during the last decade. And that's a phenomenal statistic. Quarter of our young people are suffering from mental health conditions. And wait for the next statistic. Only 47.7% in 23-24 of such patients were seen by psychiatrists. The people who needed treatment, less than half were able to access that treatment. And I'd quote from the president of the Royal College of Psychiatrists. So I'm not going to read the whole statement.
I'm going to ask
before
you
you,
to close, please.
Yeah. So I will just paraphrase briefly. It is striking that fewer than half of those experiencing mental health problems are receiving treatment. This reflects, and here's the point I'm making, this reflects the chronic underinvestment in healthcare. And our members see the consequences of this every day, and psychiatrists are having to make difficult decisions under pressure. Now, this is what you're going to have to address. And affiliated to this, I think this needs to be tackled going on to prevention aspect of it. Prevention is far better. And I'm afraid I cannot quote the reference here, but I believe for every £1 you spend on prevention, you save over £3 in treatment. And I would suggest that this starts very early, from children primary school, councils providing play equipment, physical activity facilities, drawing kids away from computer screens, socializing, physically active, mentally active. I'm sorry, I will cut short. Thank you.
No, thank you. And also, you hadn't contributed earlier, so I deliberately supported you in doing a number of questions. I try and balance out between different members, and I do respect that. Is there anyone else on workforce? I'm looking particularly at Councillor Horgan, if you want to ask one of your questions, or anyone else on workforce. Yeah, Councillor Horgan, please.
I think all of my questions are embraced by the previous speakers.
I'm going to ask you just one. You got a lot to answer there, Louis. I would ask you one. I keep reading that there are 2,000 new GPs nationally and 5 million extra appointments, but I don't hear and see those figures in Cambridgeshire and Peterborough. So are we seeing that locally? Is it true, and is it true for us?
I'll probably start with the last one. So we have seen an increase in appointments offered by GPs in Cambridgeshire and Peterborough. I think it's fair to say that we are.
I'm just being asked, could you bring your microphone closer to
sorry.
your mouth? Bring the actual whole stand like this closer to your mouth, and it
Is
will.
that better? Yes. So we have definitely seen an increase in appointments offered by our GPs, and obviously the latest change around access to GP online consultations that's now opened up will see a change as well. I think that the question I'm asking, there's a lot of detail you've given around sort of GPs, the availability of GPs, the recruitment of GPs. In the short term, there is obviously a GP funding issue, which is an ongoing debate nationally, and that will play into our ability to recruit GPs in the short term, because that is ultimately still a local GP practice decision. But the question I think we need to ask ourselves is the 5-year time frame. So what's going to happen with GP practices and the sustainability of GP practices in the sort of 3 to 5 year time frame, and then beyond that? Because I think at the moment our GP practices are dealing with everything, and they are the sort of healthcare gateway, if you like, for patients to access everything else in their healthcare pathway. And I think we need to seriously look at the future of our GP practices, because what we want our GPs to be able to do is to spend time with the patients that most benefit from their consultation. But I think we are seeing in our data that everything, GPs are dealing with housing, they're dealing with lots of low-level mental health, as someone else has pointed out. There is an enormous amount that comes through our GP doors, and I think they are the point that lots of our patients are accessing for help, and not just healthcare help, if that makes sense. And so there is a question, and again, we've sort of talked about some of that in our sort of future vision for what healthcare could look like, about is there a way in which you could channel some of that demand away from GP practices and deal with it in a different way, be that through an integrated neighborhood team, and how do we best do that in a way that it actually doesn't cause any more risk to be added to the system or to the patient in that scenario. But I think what we are seeing is GP practices being really, really busy at the moment. And if you fast forward, as I said, you'll see that they would need to do an enormous amount more to deal with the aging population that we see. And there's a sustainability question there, I think. So what we want ultimately is, there's a lot of evidence on this as well, that if you give a GP enough time with a patient, the outcomes for the patient is so much better, and you avoid quite a lot more costs further down. But what we need to make sure is that the right patients end up with our GP practices, because they can't necessarily deal with everything. So there's a short-term issue maybe where there's some GP capacity that we've got, but there's a longer-term issue which I think we're going to need every bit of capacity we'll need or we have in order to make that work. There's the general question on staffing, which I think is why we sort of looked at the kind of models we have, which is if you could. I don't want to keep using the same example, but the example on the cardiovascular disease point is important, because actually what we've tried to do there is do an at-scale approach on optimization, which means if you can optimize a proportion of your patients by doing it at scale, does that then leave you with more capacity for the patients who need a very individual approach? And that's sort of the theory behind it, because we won't be able to give an individual approach to every patient. We won't have the resource, and we want to maximize that for the patients that most benefit from it. So if a number of our patients are quite happy to go on their NHS app, quite happy to engage with us in a different way, we want them to be able to do that, and we want to maximize their care through digital mechanisms and other mechanisms that maybe doesn't need, a frontline clinician or a frontline employee to be part of it, but actually using our scarce resources for the patient that most matter. And it's the same thing that applies to GPs as well. That's the idea behind it. From a resourcing perspective, I think there's two things. One is we need to make sure that we've got absolutely productive providers, and we are as productive as we can be with what we've got, because our resources are not, in the next 5 years, not going to be constrained. So we've got to make sure that we sweat everything that we can, and we get the most out of our resources in terms of activity and throughput and outcomes. But then there's also something about, we need to be absolutely diligent in our application of any additional investment. because doing that through the right lens, making sure we understand the evidence, making sure we understand what is going to make the most difference in a time of limited resources is going to be really important if we want to create a left shift. And I think that is the role that new ICBs needs to play. It's the payer function, so assurance on what we pay for, assurance on our contract, insurance on our outcomes. But the other side of it is understanding the population, understanding what will most make a difference to our population, and allocating resources accordingly. And that, both from a capital and a revenue perspective, is going to be really important if we want to have that sort of 5 to 10 year sustainability. And then your point around mental health is absolutely important. That's probably the thing that I'm most worried about, is the wave of mental health coming through our younger people. And we're seeing that in our data. I think I used a statistic before where we've got 250 patients in our system that's used NHS services or contacted NHS services 11,000 times in 6 months, or 18,000 times, sorry, in 6 months. But a big proportion of those patients were your 18 to 25-year-old cohort. And a lot of that points to underlying mental health conditions, which is why we started the high intensity user program. But I completely agree about the point on prevention, because actually, and Sally will be aware that we're doing a big piece of work now to review mental health services with a view to redesign them, because what we need to understand is how we can get upstream for some of those conditions and prevent our younger people falling into a place where they need serious help. But anything that we can do to prevent would be much better. And that goes for prevention in general. So absolutely agree with that.
Yep. Sorry, just scheduling the order at the front here, but you're giving us some very full answers, for which I'm extremely grateful.
So it's shorter.
I'm going to go to the governance section next. I'm going to take the two people that I see, but after that, I will go to the governance section because there are a number of members who've not had a chance to take part at the moment, and I want to call them. Councillor Malinowski, did you want to say something?
Yes, thank you. Thank you, Chair. I just thought it was quite interesting listening to you just then regarding the point about GPs being stretched to capacity and trying to, make sure that the conversations that GPs are having are with the patients that need them the most. We've also spent a lot of time talking about mental health there, and Councillor Noaz raised that, and you answered that as well. Do you have any analysis that suggests that one of the reasons that we've got GPs stretched to capacity is linked to the fact that there is such a long wait time for specialist care, particularly when it comes to mental health? And that's therefore forcing people onto GP waiting lists and taking up time.
And I'd like to take Councillor Kane next.
My question's a little bit of a tangent, but given that you've raised mental health, I'm the appointed governor for CPFT, which is obviously a foundation trust. I was really shocked at a recent board meeting where they highlighted that there's no inpatient female psych beds in the whole of Cambridgeshire, which means that anyone needing that has to be sent to an out of area placement, which obviously results normally in poorer outcomes. There's massive cost implications. And the extra challenges around quality and safety, given you've highlighted mental health, I just think these are things that it's really vital we get these fixed, given the challenges we're facing with mental health. And I just wondered if something was being done to sort of address that.
So I'll take those two questions.
So I think the short answer is I haven't got specific data on mental health and the impact that has directly on GP waiting lists, but I think there is an overarching thing, which is, and we hear that from GPs, which is where patients are waiting long with little information on their pathway, they do come back to the GP to understand. So if I put it very simply, every single patient I speak to outside of the NHS says to me, I'm waiting for an operation, I'm waiting for something. I don't know if they've forgotten. I hope the referral has happened. And I don't want to make this all about digital, but one of our key aims for the future is that we make, again, it's back to the information available to patients, because we should be able to field patients with this information. We should be able to say, you are on the waiting list, you are moving up on the waiting list, your likely appointment date is on that date, even if it changes, because I think the amount of pressure that will take out of the system just by simple communication to our patients would make a big difference. And it's no different for mental health, because because actually if you're on a waiting list and you don't know when, you can't, people put their lives on hold. And actually as part of that, then if you go, well, and while you're waiting, if you're waiting for elective surgery, for example, these are the things that you could do to ensure your outcomes are maximized as part of that. So for me, there's a big thing in communication, but there is also a thing about capacity. And the reason that we were doing the mental health service review, we're doing a baseline review to understand what is being commissioned, where are the gaps, where are the need from a population perspective. We will need to look at what the model is for mental health going forward, because I think the demand coming through, as others will know, is we're not keeping up with that, and I can't see that reducing anytime soon. So we need to make sure that we've got a model that's fit for purpose, and to the other point, get upstream and prevent as much of it as we can as well. But it's sort of a two-way thing. It's a capacity and a communication thing at the same time. But it definitely, all of those things impact on our GP capacity and what it's used for, undoubtedly. And then the point on the beds, I'm not aware of that sitting here today. So very happy to take that offline and find out more about what's driving the capacity shortage. And I don't understand if it's and you may know more, if it's a short-term thing, if it's a long-term thing, if it's what the drivers are behind it. But very happy to have a conversation offline about that.
Because I think it's more than just to me, that's a massive thing that we have no female inpatient beds. And obviously, the fact that you don't know about it obviously is a bit concerning. And, obviously it was serious enough to be mentioned at a Board of Governors meeting and being something that was causing that trust, particularly a trust which is already struggling with its finances. It was causing it massive problems with finances. And I just think, given we do know that there is the challenges with mental health, it's really important that we do make sure that this mental health provision is fit for the future. And I worry with the bigger ICBs, with lots of stretching things, are we going to end up with more things like this falling through the cracks?
Yeah. So
I'm managing time a bit. I think that comment can stand, and you've kindly said that you're going to come back after the meeting.
Can I
There's
just
something
say,
you're desperate to say there, so go for it.
We're doing a review of our mental health and community services, of which CPFT is a part. And so as part of that exercise, we'll be understanding, as I said earlier, the sort of baseline, what we're spending, where the gaps are, where the need is, and then we'll come up with a set of outcomes and opportunities to address that. So I just want to assure you that it is being looked at. Just that specific issue hasn't been raised with us, but the overarching view around making sure that we've got a good understanding of what's commissioned and the gaps is absolutely happening at the moment.
Thank you. So governance next, and waiting patiently all afternoon, Councillor Dupre.
Thank you very much indeed, Chair. I'll roll my 3 questions into one as we are running short on time. What I'm asking about is the delivery of the NHS 10-year plan at the same time as a lot of other changes that are going on, including the reconfiguration of integrated care boards, local government reorganisation, and also the government's devolution proposals, which look to give the mayor a seat in the new structure around health, but not around social care, and therefore in some ways separating that off. So how do you see all of that panning out in terms of risk to the whole venture? And how do you see the new way of working actually coming into place around all of that, when all of those pre-existing and really important relationships are being thrown up into the air at the same time?
And also waiting patiently, Councillor Todd Jones.
Thank you, Chair. Yes, Councillor Dupre has mentioned a number of things that I was going to refer to. It is a bit of a perfect storm at the moment. I'm not quite sure how you're all going to cope, but in terms of, and my follow-on question is really about accountability in terms of how this is going to go forward. And I want to pick up a bit on the comments regarding the withdrawal of the contract by CUH Trust and Arthur Rank, because
could you put the microphone a little bit close to your mouth, but pull it upwards towards your mouth?
Is that better?
Yeah, great.
I've had meetings with Cambridge University Hospital Trust and with Arthur Rank, and this may not be a fair comment, but what seems to be missing in the picture is the Integrated Care Board. And given you mentioned yourself about the direction of travel, the decision by Addenbrooke Trust, which you can argue with, is not in the direction of travel, the 10-year health plan. But also the role of the Integrated Care Board, this strategic commissioning body, surely you need to have a voice in this process about we have a population that's increasing, aging, the requirements for good end-of-life care is probably going to be more important than ever. And so in terms of that strategic commissioning role and going forward over the next 10 years, then surely the Integrated Care Board must have must come forward with a voice in the current debate that's kind of been kick-started by the Trust withdrawing their contract from Arthur Rank and providing this kind of care on a general hospital site, which is surely, as I say, not as appropriate as the model we're looking to go forward with in terms of community, hospices, care at home, and so forth. So I would just like you to comment on the challenges ahead, really.
And last in this round, I'm going to take Councillor Garvey, who's also been waiting patiently.
I just wondered whether there's a timeline for each part of the process.
The simple questions are the hardest ones. Louis.
Just looking at the question, sorry. So I think there's undoubtedly a risk with the amount of changes happening across the board, and the delivery, as I said earlier, the 3 to 5 year time frame to make some of these big changes happen is vital. And it's vital because I'm genuinely worried that if we don't do something radically different over the next 3 to 5 years, that we will be in real difficulty, and it will make the waiting list that we've got today, I think, seem quite favorable, actually, because we shouldn't underestimate the demand that's coming. We really, really shouldn't. There's also, I think, some clarity coming through the reorganizations in terms of the role the different parts of the system should play in what we are trying to execute in the 10-year plan. And so if I use ICBs in an example, allowing ICBs to think about that sort of medium to long term, making sure that they are truly focused on the population, what the population needs commissioning specifically for that, and doing that with a view on allocative efficiency, using health economics, using the population need, really focusing on prevention. All of those things are really clear mandate for ICBs because that I think coming through these changes is really important. Being really clear with providers and with NHS England and the regional teams, etc., what the remit and the focus are, I think is incredibly important as well. So although it is a risk and there is a lot of change happening, and of course it's vital that we keep the changes happening whilst also changing the organizational form, is going to be really difficult. I think that clarity that comes with it is also important. And I think the clarity the 10-year plan gives us in terms of the mandate and what we need to deliver is good. I mean, I'll let colleagues in the room talk about the kind of local government changes or reorganization, but that we need to make sure that these things happen in a way that it doesn't distract us and actually moves us closer together and forces us to work much closer together, because that's the only way that this will work. On the commissioning piece and the Arthur Rank piece, I think there's a lot of commercial information, I think, involved in that discussion, which obviously we can't go into here. We, as an ICB and a strategic commissioner, have end-of-life capacity that we're commissioning, and you're absolutely right. And we've got that directly with Arthur Rank. And as part of this role that we play, we would need to continually assure ourselves we'll be held to account for making sure we've got the right capacity in place for our population and the right access for our population. And if we think to the 3 to 5 years and 10-year time frame, we also need to really think about how we develop the market in such a way that we've got the right capacity, not just now, but in the future as well, and that we understand what we're trying to do to live within that capacity. So yes, 100% the role for ICBs to play. This specific contract that we're referring to is more complex than that. And it's not a contract held by the ICB. It's something that CUH would have taken, a decision that CUH would have taken by assessing their own capacity and how they would meet the need of the demand that they've got within their existing capacity. And that was the outcome of their decision. So I think we just need to try and separate out the role the ICB would play and what we've got directly commissioned versus how CUH are managing their demand with their capacity and the decision that they've taken, without really going into the commercials of that, because I think there is quite a lot more to that issue than we are potentially discussing here as well, if that makes sense. I feel like I've missed the question now.
Councillor Garth, is about timeline.
Yes, so some of this already started, and there's a number of things that we're already doing in terms of the 10-year plan and already moving forward. But we need to get the plans for us as a new sort of system together in the next 2 months. And so by December, we would need to kind of set out how we think this will work and what the key movements are and how that will impact on demand and capacity and the key things that we're doing about it. And then, as I said, the execution of that plan then is we have to start, we've already started, and we need to move forward at pace. So I think the key thing to work out is the highest priority areas that we've already started. I refer to the community and mental health service review. There's already a mental health and community service review happening in Bedford. We're redesigning mental health services, one of our key big priorities. We've already started work on CVD prevention. We want to scale that up. We've already started work in a number of those high priority areas that I've outlined. But the next 3 to 5 years is essentially it's crunch time in order to kind of create some of these shifts. And we're also working closely with the NHS app team on switching on capabilities in our system and working with them on that development pathway. So there is a lot already in train, and we've got a very short space of time. At 3 years to 5 years sounds like a lot, but if you think about the change that we're trying to create, it actually isn't that much time. And so it is upon us. And I think from a neighbourhood team perspective, the other big element, again, there's some really good work already happening. There's a lot of work in train. We've got one of our pilot sites, national pilot sites in Peterborough. We'll be learning quite a lot from that pilot, but there is, I think, a very short time frame in the 3 to 5 years where we've got to execute these changes. But from a planning perspective, first draft in December and then sort of finalised between December and March.
Thanks. We're nearly at the end. I'm aware that Councillor Bradnam and Councillor Horgan have a number of unasked questions. We haven't covered health equity and health inequalities, which we did want to, but I'm going to leave it to both of you to choose which of your questions you'd like to put. Councillor Bradnam first.
Thank you very much, Chair. In this move from analog to digital, I just wanted to ask you, what are you going to do about the people who can't access the data or the web, or indeed might be able to now, but when they're older, can't?
And I'm going to take Councillor Horgan and then enable you to answer both together. Councillor Horgan.
I'm happy that my questions have been covered by other councillors in this section. Thank you.
Even better. Thank you. Louis.
So we're not closing access to anyone. If you need to call your GP surgery, you will still be able to call your GP surgery. I think that's a fundamental principle in all of this, is that we're not trying to exclude anyone from having access. But if there are 100 people calling a GP surgery at the moment at 8 o'clock on a Monday morning, and 90 of them we can deal with through a different mechanism, that allows a lot more space for the 10 people who do want to call, and it gives them a much better chance of getting through. And as I said earlier, that's the whole mechanism behind this, is what can we do differently to knock the volume out in a way that for patients, because I much prefer the digital, for example, because I don't have to hang on the phone. If I can be removed from that, then someone else can get through on the phone. And it's just a very simple principle, but we're absolutely not closing access for people who want to access it through the more traditional means. When we did really good patient engagement work when we were developing our digital front door, which is now absorbed into the NHS app. And we had focus groups for patients, which was truly representative of the communities we serve. And we made sure that we captured that wide-ranging set of views. What was interesting, although some people were concerned about it, but relieved that we weren't closing the telephone lines, for example, there are also a lot of people that are having difficulty accessing at the moment, for which digital tools will open up access. And we should also think about that cohort, because there was a partially sighted gentleman, for example, who said this will be a game changer for me because it means I can do so much more than I can at the moment. And there's lots of other groups that I think we need to take into account. But the principle behind all of this is not that we close anything. It's just we make different routes available to patients if they choose to use that instead. Hopefully that answers the question.
Once again, I'm going to try to summarize a very disparate number of high quality comments and high quality answers, if I may say so, Louis. I think you started with talking about the high priorities that were going to your board, but it was all about illness, not health. And I think it threw light on the fact that the prevention agenda is easier said than done. And I think as a committee and as a council, we'd be wanting to underline the importance of shifting to that prevention agenda. We discussed at length the Arthur Rank Hospice decision, not that we were scrutinising the decision, but some of the lessons from it. And certainly what I heard was that there should be an accountability mechanism if a provider or a trust takes a decision which is against the spirit of the aims of the plan. And although I understand why you say that this was a decision of the provider, not of the ICB, in the end, you are part of that accountability and should be part of that accountability mechanism. So I think that's the point we'd make to you. But I think we'd agree with you in terms of the objective that having alternatives for end-of-life care, which don't necessarily mean going to hospital where the choice is there, is really important. And you did accentuate that, and I think we'd want to agree with that. You talked on a number of occasions about integrated neighbourhoods and not allowing the organisational changes to take you off the path of making progress in terms of integrated neighbourhoods. I think we'd definitely want to support that. You talked about hoping that in that organisational maelstrom that you hope that some of the clarity the 10-year plan gives you is going to enable you to still make progress in a systems way. But there was a bit of other, one side of the system and the other side of the system, and not a whole description of systems thinking and systems working. And I guess we'd want to push you in that direction. I think you gave some very good examples around digital risk scores and enabling health professionals to meet the people who need you most. You spoke in favour of an integrated digital approach, not having 5 NHS different apps on your phone. And you talked about the good work being done on high density users by this council, and also the work being done with public health. I guess we'd want to support and encourage all of that. You drew attention to the concern about electronic patient records at NWAFT and the need to bring them up to speed. So I guess that we'd want to support that, but also ask you to send information back with us in due course about that, we hope, being achieved. On Healthwatch, you did say that you very much valued the patient engagement that Healthwatch provides. And I guess what we'd say to you there is to address the issue with some urgency, given what we heard from Jess later today about the timescales that they're planning to, and I think that applies to our own council as well as you, and the potential for partnership working. I'd be the first to accept. We heard from Councillor Dr. Nawaz about GP availability, and perhaps there are more GPs available than might be thought, but they're not getting to the right place at the right time. And I think what I heard from that is urging you to look at short-term actions that might exploit the resource potential there is to improve GP availability within our catchment area. We heard you make the argument for allocating resources where they make the most difference, a population health management approach. I think that's generally very strongly agreed between this council and yourselves, so I think we'd want to underline that. We heard from Councillor Kane, which you weren't aware of before today, the lack of inpatient female-only beds for mental health in Cambridgeshire, and you've promised to come back to us with more information about that, as well as explaining that mental health services are under review. You've said that patients should have information of when and where they are on waiting lists. What a simple thing to say, and what a big distance we are from achieving it. We won't leave that off the conclusions list. We heard from Councillor Garvey about timelines, and we've heard from you repeatedly your belief that these shifts have to be visibly made within 3 to 5 years, not least for resource challenge reasons. So I think we'd want to note and acknowledge that. And I think, although we heard in your last answer to Councillor Bradnam about not wanting to exclude anyone, I think it's right that this council expresses concern about the potential for digital exclusion and asking you to pay every attention to efforts to ensure that is not the case. Do any other members want to add anything that I've not referred to? Councillor Dr. Noes.
Thank you very much. I have a serious worry, and I think it's widespread concerns about digitalization and the information that the NHS will hold. Now, with the population-based rollout of the genome project, and that means that the NHS will hold information about the complete structure of the DNA in every gene, what it does, what it doesn't do, what it shouldn't do. It is practically whole of an individual's life is encoded there. That coupled with the fact that they're talking about unification of digitalization and making it more easily available for sharing, as well as the fact that the design of this digital information, I know we are told about the anonymity and anonymized form and pseudonymity and pseudonymized information, but these two aspects are reversible. And on top of that, if the provider of digital analytics is not British based, do not have the highest level of security clearance, I would worry about that.
Okay.
How will you address these worries, please? Thank you.
Thank you. Those are extremely interesting questions. I'm struggling a bit because it's the end of the session and it's a new question rather than one that I'd missed in the summary. Can I just look, but not unimportant. I absolutely accept important questions. Just before I decide what to do, is there any other member who feels in my summary something was missed out that you'd like to see in? Councillor Pitt.
I mean, sorry, summary is very thorough. I just wanted to flag the two things that really rang home to me. One of which was standing still is not an option. You talked about the demand, the expected increase in demands that are coming. So something has to happen. And then Councillor Dupre's reference to the numbers of changes across the ecosystem of health and local government. And I think those two are going to hit each other quite hard, really. So, you know, I think I get the sense you're a systems thinker and systems leadership, which is clearly relevant to the whole process of designing, you know, redesigning this enormously complicated ecosystem. But I do feel, with apologies, I make a very small point. I think like it has to be kind of not really the quick wins, but the big wins. What are the simple things we can do quickly? Because that 3 to 5 year, we're not going to redesign the whole system in 5 years. So what are the big impacts that can happen quickly with that population health and prevention? And that's the thing I'm really looking forward to seeing more of and hearing more of in future.
Right. What I'm going to rule is the quick wins, send it to us afterwards, because we've reached the end of the line, and we also are inviting ICB back in December, and that will be a chance, I think, to discuss that again. I think Councillor Dr. Noes's question is so hanging in the air that a member of the public watching this would feel it's strange if there wasn't a short answer today. So I'm not asking you to give a long answer, but I think I will invite that.
Thank you. The first thing to say, and I'll be very brief on this one because I can talk about it for a long time. Our data capabilities will fundamentally change the way we can do healthcare. I'm a fundamental believer of that, and I don't think we're maximizing that enough in the short term. The use of genomics and the ability to target accordingly is a game changer for healthcare. Currently, we're doing things to patients that will never work. We're giving chemotherapy and expensive treatments to patients that their genomic sequence will indicate actually is going to be ineffective, and they spend the last 12 months of their life going through in and out of hospital on very, very invasive treatments that probably won't have an impact. So the use of our genomics in terms of how we target treatment for patients to make sure that they are getting the treatment that's most effective for them is a game changer, and we should not underestimate how that will improve the outcomes for patients in the medium term and in the short term. The use of genomics to understand the potential risk profile for a patient is a game changer as well. If I'm predisposed genetically to cardiovascular disease, and I'm a smoker, and I'm overweight, and all these other things, that's a very different risk profile to someone that's not predisposed necessarily genetically to cardiovascular disease. So how we use genomics in the targeting and the prevention agenda is going to be very, very big, and as well as the targeting. And I can give you lots of different examples, which I won't do now because we haven't got time. And now we could really use genomics differently in healthcare for the better of patients. In terms of how we use data, there are very, very strict laws governing the use of data and who can access data. And we have to do all those things in accordance with the law. And so I think we need to hold on to the fact that we have to abide by the law of the country and GDPR and all of those different mechanisms that guards how we use data. And regardless of where the platform sits and who runs it, we still have to abide by the laws of the country when it comes to access of information and how we filter that to different providers who can and can't access. So I just want to give assurance that there are really, really strict laws governing that, and we can't just reverse it because we feel like it, because we have to adhere to the rules and the regulations that are in place.
But clearly there are questions, as we've heard today, about whether the protections are satisfactory or not. It may well be we decide to do more health scrutiny on that subject in the future, but I think for today at least there's been a chance for your question to be answered. It's been a long session. It's always a pleasure to see you, Louis. We wish you success. We'll see you and colleagues back in December, but that closes this section, and thank you very much.
Thank you very much for your time.
Members, please stay on because we've got the last part, and although it's near the end of the afternoon, people are happy. Yeah, okay. People are happy that we follow the same procedure, that Rishenda, having listened to the summary and taken her notes, will draw up conclusions to then be agreed with the Vice Chair and myself. Are people happy that that is the process? Yeah, great. So we now move to Health Scrutiny Work Programme. If you look at pages 61 to 98 on your agenda papers, that refers to all of this, and I ask Rishenda to address the meeting, please.
Thank you, Chair. So the topics for December have previously been agreed by this committee for scrutiny. So that's dental provision in Cambridgeshire, and also the implications for Cambridgeshire and Integrated Care Board cost reductions and reconfiguration. So building on today's discussion. I won't go through the whole report, but Appendix 2 looks further ahead and is looking at potential scrutiny topics for the meeting in March 2026. That includes topics that were collected previously by the Adults and Health Committee when that was delivering scrutiny, plus new suggestions by committee members here. It gives a very rich list, as you will see, but there also, of course, might be other topics members have in mind. So we're just looking really for a steer from the committee on what you would like to schedule for the March meeting. And then looking further ahead, we're talking about the arrangements for producing a draft work programme for 2026-2027. So we've suggested the same process as last year, inviting suggestions from members of the council, obviously from key partners like Health Watch, and assessing them against agreed criteria. It may well be as well that some of the topics on the list currently you might like to carry forward for consideration. And what we're suggesting is that we pull that together into quite a long list of topics and then have a committee workshop in January for you to look at that and decide about your priorities from that. Thank you, Chair.
Thank you. And the only thing I'd add to that is there's a certain amount of planning ahead that to get the people we want, we do have to give them enough notice. And so that's why we always need to be a couple of cycles ahead to make sure that the priorities are there. And I can assure you that the Vice Chair and myself are closely talk with our officers about that and try to make sure that the wishes of all the members are properly reflected. Let's just see whether we have a workshop in January or not. There's a bit of meetings overload, but if there's a need for it, I'm absolutely happy to have it. But what we're going to do is have a short round now. We've already got the suggestions that are in the paper. Let's just hear if people want to add to that or comment on that. So we'll have an open discussion for a few minutes about priorities, and then Lucinda will take that away and discuss with Councillor Bradnam and myself, and that might clarify things a bit. And Councillor Bradnam's going to be first.
Thank you. Thank you, Chair. I just wanted to check that Rashenda will incorporate some of the things that have come out of today's discussion when we've asked for reports to come back. Certainly in the first paper, we asked for quite a lot to come back to us, didn't we? And I'm just wondering if those will be incorporated in the work programme.
Again, just to help the discussion, some of that is the recommendations tracker and making sure that information that we've already asked for does actually arrive and we see it. Some of it, like the discussion at the end about digital privacy, might be a suggestion for a new topic. So that covers both of those. I think that would be fair to answer. Councillor Horgan.
Yeah, I've submitted a topic for future consideration via Rashenda. I've been contacted by a number of people regarding the intermittent and sometimes very unreliable supply of medication via pharmacies, particularly for treatments such as ADHD. And there is, on my own council, a member who suffers from ADHD, and on occasions he has run out of medication. And it's of great concern because without that, people are unable to function.
Thank you. Yes, please. Councillor Martin.
Thank you, Chair. Recommendation for the March meeting would be to have a discussion and maybe take up both slots with the NHS oversight framework that came out last month. So obviously March will be a 6 months since then, because obviously that covers both of our foundation trusts, our ambulance service trust and the ICB. So it covers 4 parts of the health sector within Cambridgeshire and Peterborough, or Cambridgeshire more specifically. So I think a 6 months update on where they're up to, whether each of the trusts are up to with that framework, and see what progress is made, because I know that they're all in either segment 3 or segment 4, which is in the lower sections of the framework, would be useful for us to see and hear.
Thank you. I'm not speaking for or against that, but there's obviously a balance between homing in on very specific service orientated questions and those bigger oversight type questions, and balancing the two as we've sought to do today. But I take very much that suggestion. Anyone else? Yes, please, just later.
So given the situation about Healthwatch and your positions in the community, I think March should be around what the ICB and the councils are doing around patient voice and public voice. So the progress between, I think December's too early, but certainly March, on those conversations about how the functions will work in the longer term. So you could scrutinise that, and I could do a review for you.
Thank you. I think, again, I know the Adults and Health Committee of the Council is going to be discussing Healthwatch in March. Whether that's the best forum, or whether Health Scrutiny is the best forum, or whether both are, I think probably there needs to be some reflection about. I'm just looking to my left in case there's a strong view that needs to be put today.
Well, I think they're the same topic, but I think they're different scrutiny. You might want to scrutinise the ICB's view around patient voice, and the council will have its own governance arrangements around its voice for the population of Cambridgeshire. That might be through a committee, it might be through other mechanisms. It could be a conversation at Health and Wellbeing Board.
Yeah, so I think what I'm hearing from that is that there's room for reflection. Yeah. It needs addressing, but how we do it, there's room for reflection. That's why I hear on that. There was somebody else who I saw. I'm sorry, it was Dr. Noel.
Just a quick observation. I'm wondering that some of these subject matters are so wide-ranging with such important implications. Perhaps if we have fewer speakers, but be able to interrogate the subject matter more thoroughly in greater detail. Thanks.
It's an interesting one. We've tried some different things over the years, and we're always open, and I'm always open to suggestions. As the chair, I always try to ensure that each member has a chance to put their question that they're interested in, and that no member gets excluded from that. And that does inevitably mean a wider number of questioners. But I am open to that. And in the informal preparatory meeting we have, perhaps we can just pick that up again, where we can have more of a dialogue about it than perhaps we can do in a short amount of time here.
Chair, it's absolutely no criticism of you chairing the meeting. You've been very fair. I've seen that. But I think it's just the time shortage. If we have so many speakers, we just haven't got the time. And some of us have, I'm sure, put in so much work and research into these things that we don't feel that we have interrogated that particular subject to our satisfaction. So just a suggestion, less but in greater detail, that's all.
Yeah, and again, there's definitely a case for that. What I think is when we have our preparatory meetings, let's focus on that, because that means some other members saying, no, I'm going to step back on this, and allow another member to be able to spend a bit more time interrogating. Councillor Bradnam.
Thank you. I understood Councillor Nawaz to mean fewer public speakers, so that we could interrogate them in more detail, not fewer members speaking. Sorry, is that what you meant? Okay.
Is it?
I thought the chair understood what I was saying, but perhaps not so clear.
I'll just
less of those speakers, and more of us interrogating the topics, rather than less of us. I mean, the whole reason for us being here is to convey the public sentiments, the public concerns, and that may need more time and a bit more toing and froing than we are able to do because of less time we have. Not criticism of your conduct, but just an observation. Thank you. A suggestion.
Okay, no, it was a helpful clarification, so I had misunderstood it. Thank you. Let's reflect on this in a preparatory meeting. I think to say to one of the health partners, you come in for 3 hours, button yourself down, we're going to give you a great old grilling. That also is quite a tough message, but maybe we should try it once and see how it goes. Let's be open-minded. I thought Councillor Garvey, I believe.
I don't know if you've gone off topics, but those neighbourhood hubs that they're talking about, it'd be nice to hear a whole lot more about how it's all going to be organised.
Yeah, I think that's very fair. That also impacts social care, doesn't it? But let's put that on the list from Councillor Garvey. Okay, we've got some good additional suggestions there. We'll take a first look at it and come back from some recommendations. Next, we're being recommended to take up an offer by Cambridgeshire and Peterborough NHS Foundation Trust for a site visit. And Rishendra is just going to give us a bit of background to this.
Yes, thank you, Chair. So the Chief Executive of CPFT did offer a post-scrutiny site visit when the Trust's mental health services were scrutinised in January. Since then, the Care Quality Commission issued a report in July that downgraded the Trust's rating for well-led from good to requires improvement. So it's a question really, or a recommendation that the committee may like to carry out a site visit, but expand it to cover both of those. Thank you, Chair.
And the experience in the last period of office of the council is that when we did the site visits, they were rather successful, and I think people on both sides enjoyed it. So I would definitely recommend that we do this. Always there are dates, and not everyone can do the date, but are you happy that we recommend that we try to do this? I'm seeing nods. Yes, that's great. And then another additional question to be put to the meeting is that we're being recommended to request more information about an external clinical review and independent investigation into a trauma and orthopaedic consultant's practice at Cambridge University Hospitals NHS Foundation Trust between 2015 and 2025. I think people will recognise that's very sensitive from what I've read out. So again, I'll ask Rashenda to comment, please.
Yes, thank you, Chair. So obviously this is an ongoing issue. It has been an issue of public concern. Members may have seen there was a report in local news yesterday about this as well. We're suggesting at this point that the committee might just like to ask CUH to provide a copy of the external review once it's available and any action plan that they draw up. So that the committee can reflect on whether scrutiny would add value in this case without duplicating the existing work.
That seems to me to be a no-brainer. It's just us writing a letter and getting information. Everyone happy with that? Agreed. Yeah, lots of nods, so that's agreed. We then have the recommendations for the report to note the work programme. We've discussed, not decided, topics to be scrutinised in March, but we've taken the temperature of the members at this meeting. We've approved the arrangements for producing a draft health scrutiny work programme in the light of what was said earlier. We take up the invitation for a site visit to CPFT, and we do request a copy of an external clinical review and independent investigation into a particular consultant NHS, Cambridge University Hospitals NHS Trust. Are people happy to agree those recommendations? Any objections from anyone? I'm seeing nods all around, so they're agreed unanimously. Next, the recommendations tracker. Some of this is inherited from the previous council, of course, but it's an important item, and in a way we're responsible for ensuring the legacy of the previous council's work on this, but also very quickly the tracker will include new recommendations that have been inserted from meetings such as this. Again, do you want to comment in any way, Rashenda? This is page 199 to 106 of your pack.
Yes, so I think, as the Chair says, this is something that was introduced by the Adults and Health Committee, and it's really just to ensure that the recommendations, the scrutiny recommendations that the committee makes, aren't lost, and that the committee does retain oversight of them. There's no requirement for the NHS organisations to accept any recommendations that the committee makes, but they are required to consider them and to respond to them. So it's just a way of making sure that that does happen. Thank you, Chair.
Everyone happy with the recommendations tracker? I'm seeing nods. So, yes, please, Councillor Bradnam.
Just one I noticed there on page 103, there's the record from the meeting on the 12th of December 2024, and it refers to urgent and emergency care, and it was paused pending the election, and the status is ongoing. I wondered if we wanted to pick up on that.
Can I just ask Rashenda first to comment on that?
Oh, there's another one. Sorry, below it. Okay. Saying completed.
Yeah, Chair, I don't know off the top of my head. I can certainly check that and come back outside of the meeting.
Okay, so we'll pick that up in some of our discussions outside the meeting. Just check nothing's been lost there. Elections, they get in the way, don't they? Thank you very much to all members and all officers for, I think it's been quite a meaty meeting today. We've dealt with some really serious subjects. Please reflect upon it, and then when we next meet informally, please, or just bilaterally, any time you wish, please do give feedback on what worked and what could be improved. We're a new committee and we have many new members here, so please do feel free to give us your comments about how we've done it and how we can further improve again. But with that, thank you very much to everyone, and I declare the meeting closed. Yeah, I'm not rushing. I'm gonna just have a quick word with Ross. Ross, are you running? I'm not. Kind of bending you about.